கொலாஸ்கோபி பயாப்சி ரிப்போர்ட்டா? சப்போர்ட்னு வருது. நான் இது ரெண்டும் ஓபன் ஆச்சு. டிஸ்சார்ஜ் சம்மரி இதுவும் எம்எஸ்ஐ ஐஹெச்சி அது வந்து நாட் சப்போர்ட்டட்னு வருது. கொலாஸ்கோபி பயாப்சி ரிப்போர்ட் கூட
RX events can mute them.
நாட் சப்போர்ட்டட்னு வருது. ரெண்டும் இது ரெண்டும் தான் ஓபன் ஆகல. பட்
Good evening, Sudarshan sir. Anand Vasudev sir, good evening.
Yeah, no.
Good evening, everyone. Good evening.
Very, very good evening, everybody. Yeah.
Congratulations, Dr. Sudarshan.
Oh, no, sir. No.
Today's newspaper has got your.
Namaskar. Congratulations.
Oh, no, sir. Namaste. Thank you. Thank you.
Congratulations, sir, from my side.
Thank you. Thank you. Thank you. Yeah.
Sir, congratulations.
Oh, thank you.
Ma'am, I think you are live, right?
Yeah, yeah.
You can start.
Yeah.
So we're going to start opening remarks from Jairaj.
Am I giving the opening remark? I think
Yes.
Girish Mahadev was supposed to give. I'm actually attending a wedding, sir. I've just moved out some few kilometers just to avoid that Sangeet music. I'm sitting in a restaurant. Now I'll go back. Anyway,
Jairaj, we missed you last week when I came to Bangalore.
correct, sir. Absolutely, I missed you. I couldn't see you getting honored. I had some other. I had gone out of station.
Nowadays, you attend a lot of marriages.
RX event, are we live?
Yes, ma'am. I've already informed that we are live.
Yeah, but can you start then? Put Girish Madev's, then mine.
Yeah,
You
Girish
start
is there? Mr. Girish, you are there?
My slides, are you
I think
sharing
RX event
or?
is RX
should
event
I-
is starting the things.
Yeah, okay. Girish is there. Girish will give the inaugural remarks, and we'll just.
Good evening, everyone. On behalf of Microlabs and Microknowledge Academy, I welcome you all for the 6th annual conference of the Fever Foundation, FCON 2023. We are being honored to be a part of Fever Foundation, and it's become a moral responsibility for us to involve ourselves into new scientific events, national quiz programs, and building patient-centric initiatives. We also want the responsibility of disseminating the rich scientific content of FEFCON in reaching to more HCPs in the form of fever CMEs, videos, snippets, and the reading materials in the form of FEFCON books. Microlabs is one of the top 20 companies in India and has a strong presence in 55 countries across the globe. And we are one of the predominant players in fever and pain management, anti-infectives, cardiometabolic, psychiatry, ophthalmology, and critical care segments. Our 14 state-of-art manufacturing plants, the R&D expertise, the API capabilities, marketing and distribution has made our quality products at affordable prices for consumers. The whole credit of organizing FEFCON 2023, the national events, definitely goes to all the founder members of Fever Foundation and the scientific committee members. I welcome all the speakers and the healthcare professionals who have been participating in FEFCON 2023. From Microknowledge Academy, we assure our continuous support to Fever Foundation in conducting scientific initiatives and the future projects. So without further delay, I hand over the sessions to Dr. Manjula. Thank you.
Good evening, everyone. It gives me immense pleasure to welcome you all to this session. And I have the privilege of welcoming our honorable faculty as well. And this is the 6th annual Fever Conference we are conducting. And this time the theme is fever, bench to bedside. So before I go to this, I thought I'll give a very brief about Fever Foundation and its journey so far. Fever Foundation is an independent, non-commercial foundation supporting the educational and academic activity to address the unmet needs in fever management. The vision of Fever Foundation is to strive towards imparting knowledge on the unmet needs and to provide information on research, education, and therapy updates on fever management. Fever Foundation is committed to conceive, build, and sustain program and make scientific initiatives which are aimed at providing evidence-based update to healthcare professionals. With regard to activities related to Fever Foundation, we have annual fever conferences, we have fever CMEs, we bring about books on fever management, we conduct clinical epidemiological research, and we conduct competitions such as challenging case presentation competition, quiz competition for postgraduates in medicine and pediatrics, Young Scholar Awards, patient education, paramedical education, public awareness, and the parent awareness activities. With regard to Fever Conference, FEFCon, which is a Fever Foundation conference, we have done 5 conferences so far, starting from 2018, 19, 20, 21, and 22. See here, we are here with the 6th conference. Last year, we had highest 50,000 plus registration, which won the Asia Book of Records. Then here we are on the 6th. I'll come to this conference a little later. And with regard to the book, Fever Foundation brings about books on fever management. We have brought in 11 books, which is on fever management, both for pediatric practice as well as internal medicine. And also during COVID, an exclusive handbook on COVID also was brought in. So there are 11 books which are available for free download. If you go to the lobby, you go to the on the platform. Yeah, so you will be able to download the books. All the books are available to you for the download. Then with regard to fever CME, we conduct fever CME across India. We collaborate with several medical associations. We have conducted so far more than 100 CMEs. We have touched covering around 15,000 doctors. We have the modules include management of fever in children, management of fever in adult, and fever in special situations. And today we are here for 6th annual conference FEFCon, which is themed as Fever Bench to Bedside. It is a 3-day conference, 17th, 18th, and 19th November. So just now our IT partners have told us we have a record number of registration. We have 65,000 registration, which has happened so far. Thank you all very much for joining in. And what are the scientific session in these 3 days? Day 1, which is Friday, which starts from 6:45 onwards till 9:30. We have the sessions, which is a common hall, which is both physician and pediatric common topics will be discussed today. Tomorrow, it is divided into 2 halls, physicians hall and pediatricians hall, which starts from 7 p.m. in the evening. So in the physician hall, topics related to internal medicine will be discussed, and pediatric hall, the topics related to pediatricians will be discussed. Tomorrow morning, we have the exclusive workshop starting at the breakfast session, 9 to 10:30. And I'll post that. We have the regular session in 2 halls, physicians hall, which is Sunday. I have to tell you, it is in the morning. So we are ensured that we don't miss the World Cup. So 9 to 1:30 is the session, 9 o'clock to 1:30 is the session. So 9 to 10:30 is the breakfast session, and 10:30 a.m. onwards, we have the regular session. And also, I would like to inform you that on the lobby, you find a poster display hall. All the posters submitted for the competition are displayed in the poster hall. So you can see at your leisure it is there from today onwards till the conference ends. With regard to the highlight of this conference, as I got the data was more than 50,000. I know the exact data as of right now I'm speaking, it is 61,000 registration. And we have delegates included, both national and the international delegates, and speakers of national and the international reputes are here. It is accredited with credit hours by Karnataka Medical Council. And we have dedicated hall for physicians and the pediatrician. Inaugural keynote address will be given by Dr. Soumya Swaminathan, former Chief Scientist of World Health Organization. Shri G.C. Surana oration is rendered by Professor G. Narsimulu sir on the topic Enigma of Pyrexia and SLE. So we have an exclusive breakfast session. The title this time is for the workshop, Mastering Diagnostic, the Clinician's Dilemma. And the regular popular sessions are there: pro-con debate, clinico-pathological case discussion, and the panel discussion. And we had 2 postgraduate competition, national PG quiz, and then national poster competition, which both internal medicine and the pediatrics, which has been completed. After my session, we'll be announcing the winners. And before I close the session and announce the winner, I have to thank our extremely eminent doctors who are part of our advisory board members, starting with Dr. Maya sir, who is a patron. And we have all the doctors: Dr. A. Muruganathan sir, Dr. T.S. Ravindra sir, Dr. Isaac Moses sir, Dr. Shankar sir, Dr. Ravi sir, Dr. Nagraj sir, Dr. Anupam Prakash sir, Dr. Hemant Thakkar sir, and Dr. Gansham sir, Dr. Shekhar Chakravarti sir, the Jayan K. Panda sir. All of them help us in the physician adult internal medicine aspects of conducting the scientific activity. Our pediatricians advisory board includes Dr. Jagdish Channappa sir, Dr. Bhaskar Shanai sir, Dr. Sukumaran sir, Dr. Anand Keshavan sir, Dr. Anand Vasudev sir, Dr. Rachna ma'am, and Dr. Chetan Trivedi sir, the Ignesh Popat sir. So thank you very much for helping us in the pediatrics. So our epidemiological expert, we have Professor Dr. M.K. Sudarshan sir, and then oncology expert, we have Dr. Shekhar Patil sir. Rheumatology experts, we have Dr. Narsimulu sir, Dr. Chandrasekhar sir, and ID specialist, we have Dr. Suresh Kumar sir. So I thank each one of them, without whom this scientific session, all the scientific activities of advisory board would not have been possible. They are actually hand-holding us and helping us with all the scientific activity, and thank them for this scientific fiesta. Thank you very much, sir. So I close my slide, and I would like to ask the RX event to share the slide on winners of quiz competition as well as poster competition. So we had the national level first, we had the zonal level quiz, then the national level quiz. For in the internal medicine, we had the first place by Nilanjan Mal from the Rajendra Institute of Medical Sciences, Jharkhand, and the second place was Rahul Kamaria from Usha Medical College, Gujarat. Congratulations to both of you for winning the FEFCON Internal Medicine quiz competition. Next slide. Then for the FEFCON Pediatric quiz winners, first place goes to Dr. Weber from the University College of Medical Sciences, New Delhi. And the second place goes to Dr. Sanya Singh from Indira Gandhi Government Medical College, Maharashtra. Congratulations to both of you. Then the poster competition in the pediatric section, first place was go to Dr. Aman. She's from the Osmania Medical College. Second place go to Dr. Darshita, RCSM Government Medical College, Kolhapur. Congratulations to both of you. Next slide. For the internal medicine competition, first place go to Dr. Sri Lavanya from MKCG Medical College. The second place go to Dr. Mayank from the Government Medical College, Haldwani. So congratulations to both of you. So all the quiz winners and the poster winners, Fever Foundation team will get in touch with you and hand over your prizes, and our team will be in touch with you. Already they have met all of you, and they are going to give you the certificate as well as the prize which has been announced. So congratulations to both of you. Now to move on to the next session, we have a welcome address by our patron, Dr. Maya sir. Can I have the slide of Dr. Maya sir, please? See, Dr. Maya sir is the eminent physician who does not require any introduction. And entire world knows Dr. Maya sir. So, but as a formality, I'll be doing, and it's my privilege to do so. Dr. Maya sir is the chief patron of Fever Foundation of India, former professor of medicine, Karnataka Medical Services. He's a senior physician at Rangoday Memorial Hospital. Sir is also chairman of Medical Education and Research Trust of Karnataka for the past 40 years, who do the lot of activity of postgraduate training programs. And he has been has done a lot of awards and accolade. He has double FRCS from London, triple FRCS, London, Edinburgh, and Glasgow. And sir has got the distinguished award from API, Infosys, and also he holds the Doctor of Science degree from Rajiv Gandhi Health University, and he has the Master Teacher Award. So he's been very, very active with us with Fever Foundation, helping us conducting all the scientific events of this Fever Foundation. Thank you very much, sir. I welcome you to this program. May I now request you to kindly give your welcome address. Over to Maya, sir.
As a part of my welcome speech, I would like to talk few words about fever. As you all know, fever is a prominent but common feature of diseases and since antiquity. And whenever I was thinking about fever, I always I recollect the saying of William Osler, that is, humanity has but three great enemies: fever, famine, and war. Of these, by far the greatest and by far the most terrible is fever. Of course, he mentions it as most terrible, but actually fever is a host defense response. The normal temperature is about 36.7 to 37.2 degrees centigrade. But the fever may be of various patterns. It could be continuous fever when the temperature is maintained 37 degree, a variation less than 1 degree centigrade. It could be remittent when the temperature persists above normal, fluctuates more than 1 degree. It could be intermittent, where elevated temperature for some time and remits to normal, and relapsing fever spikes with intermittent and normal temperature for days and weeks. The pattern of temperature helps us in the diagnosis of fever. The characteristics of fever, that it is a very common and a unique manifestation. When it is so unique and common for several decades, why is it doctors did not think of having a society or a conference or association? When you compare to the other associations like hypertension, diabetes, rheumatology, etc. The reason for a need for this association and studies is due to the character of the fever. You know, it is a common manifestation of both common and uncommon infection. And also, it can represent other diseases like cancer, collagen vascular disease, and even a drug fever. Secondly, this fever is seen in all parts of the world, whether it is south or north, east or west. So every doctor in any region has to know things. And thirdly, it is a fever is seen in pediatrics as well as geriatric population, in pregnant and non-pregnant persons. And this fever is usually seen by a family doctor. This family doctor may be an Ayurvedic or a homeopathic or allopathic one. But even the patient is able to tell something about fever. Any fever, a thorough bedside examination with very few common investigation, we will be able to help the diagnosis of fever. If the etiology or the cause of fever is not recognized for 3 weeks, even after a week's detailed study, then we call this as fever of unknown origin, or PUO, that is pyrexia of unknown origin. And this PUO or pyrexia of unknown origin remain as unknown origin if the fever becomes normal without our knowledge, or the patient dies before the diagnosis is made. Because of these reasons, it is very important that we have to form association and scientific bodies. So some of our doctors thought we should have a fever association, and we were ably supported by Surana family and Microlab. And to our great surprise, when once we form an association, there is a total response from all over India, and now at present every state has got a fever association, and even at district and taluk level. So we find that regular activities about fever and scientific sessions are being held all over India throughout the year, and we are hosting this 6th conference of National Conference of Fever Foundation of India. And this Fever Foundation is an independent, non-commercial foundation supporting the educational and academic activities to address the unmet needs in fever management. The foundation is committed to conceive, build, and sustain programs and make scientific initiatives aimed at providing evidence-based updates to the healthcare professionals. I am sure at the end of this conference, many of our postgraduates will be in a better position to manage the fever, and being a very common problem we face every day. Thank you.
Thank you very much, Maya sir, for excellent welcome address, and it has set a very right tone for the entire FEFCON conference. We'll start with the first session of the day, which is cytokine release syndrome. To talk about the physician aspect, we have Dr. Chandrasekhar sir. And to introduce our speaker and the moderator and the chair session, we have Dr. Ghanshyam Pangte sir. Can I have Dr. Ghanshyam Pangte sir? Yeah. Sir, Dr. Ghanshyam Pangte sir is a professor of medicine at Lady Hardinge Medical College, New Delhi. He's in charge of rheumatology and medical ICU at LHMC Medical New Delhi. He is a Joint Secretary of Indian College of Physicians and API Delhi Chapter, Executive Member of Delhi Rheumatology Association. He is Associate Editor for the API Textbook of Medicine. He has published more than 100 papers in indexed and non-indexed journals of reputed journals. He's co-edited several books, includes a few of them, Pearls of Scientific Paper Writing, Research Methodology, Ethics in Clinical Research. And he's also examiner for MD and postgraduate, and he's also teacher for MD and DNB students. So, Professor Ghanshyam sir, it's our pleasure and privilege to have you, sir. Can you take over and chair the session and conduct the session for us, sir? Over to you, sir.
Thank you very much, ma'am. It's my pleasure to be part of your Foundation's 6th annual CME. And today it's my honor also to be part of the inaugural session. And it's my pleasure to introduce Dr. Chandrasekhar S., who is our Indian Rheumatology Association President-elect, and he will be taking over as the President by the month end in November and during our national conference. Dr. Chandrasekhar is Medical Director, is Chandra Rheumatology and Immunology Center and Research in Bangalore, Karnataka. He's already told you that he is the President-elect of IRA. He is also President Indian Rheumatology Association Karnataka Chapter 2019. He was General Secretary Society of Inflammation Research from 2016. He is also Managing Trustee the Immunology Arthritis Research and Education Trust IARET. He is also holding the post of Executive Editor of Chandra Journal. He is also Faculty and Program Coordinator of Post-MD Fellowship in Immunology Rheumatology in CRICR. Sir has already received so many awards. He is very eminent researcher also. He got State Award for Research in 2015, Sir C.V. Raman State Award for Young Scientists. He also received IMA Pune Annual NIO Oration Award from IMA Maharashtra Chapter. Sir has received Oration in 2013 from Indian Rheumatology Association. And also in 2000, he received Dr. Malaika Reddy Oration Award. He's already published more than 100 publications in national and international journals. His special interest is autoimmune disease, recurrent pregnancy loss, and silico modeling. And today he will be talking on very important topic in fever as well as immunology, rheumatology, cytokine, physician perspective. Know that recently so many advances has been done in genetic studies and all. There's new NGS sequencing system has come up. So a lot of patients are getting CRT therapy or a CART therapy. They are going into a cytokine storm or a cytokine release syndrome. A lot of patients of our sepsis, severe sepsis like dengue or this EBV infection also get this cytokine storm release syndrome. They do affect. So it's important for physician, it's important for immunologists, rheumatologists, pediatrician. A lot of primary immunodeficiency patient may go into HLH. So this is important for everyone, from hematologists, critical care specialists, to rheumatologists, to general physician. So sir will be talking on this important topic, cytokine release syndrome. It's over to sir, Dr. Chandrasekhar sir.
Thank you, Dr. Ghanshyam. And
yes, welcome.
Thank you to Fever Foundation for giving me an opportunity to share about cytokine release syndrome. I think I'll share my slide. I think it's visible.
Yes, sir.
Yeah, right. Okay. So I think in the next 15 minutes, I would like to share about one is
yes,
it's visible. And how this concept can be extended to the managements, and what really is the cytokine storm. The COVID infection and the COVID pandemic made us sensitive to the already old terminology which was introduced down in 1991, what we call cytokine release syndrome or cytokine storm, and so on and so forth. The cytokine storm is considered as one of the life-threatening disorder involving predominantly cytokine elevation in addition to immune cell hyperfunctions. See, why I still use a word adjective called predominantly cytokine elevation, because as we dissect out this cytokine storm, what we previously described, and some of the syndromes which are put in the basket of cytokine storm or cytokine release syndromes, are maybe partially cytokine driven, partially stimulated or initiated by cytokine storm, taken over by the other hematopoietic cells and immune competent cells. So overall, this cytokine storm for non-immunologists and the people who are new or new to immunology concept, just to make them understand. See, in any infection or any trigger of immune system, what is normally anticipated is it should be a highly well-balanced offense. Say there is a bacterial infection or a viral infection. Normally what immune system does is it identifies, recognizes, fights, releases varieties of proteinaceous substance, which includes cytokines, which includes immunoglobulins, utilizes a lot of proteinaceous substance like complements, C-reactive proteins, etc. Ultimate with an idea or a concept to drive away the stimulating or an igniting factor. And once that is done in a balanced manner, slowly quench it down so that whatever the immune response or inflammatory response or a response which has come as a bouncing should slowly taper down and then slowly dwindles down back to a normal homeostatic mechanisms. When this gets disrupted, when this doesn't happen in the way it is expected to happen, we may land up in what we otherwise call a cytokine storm or a cytokine release storm. It's not a new concept because most of us got sensitized to this term in the last 3 years or 4 years when we heard time and again with COVID infection that individual may go into cytokine storm and we lose these patients. It was first described as a concept down in 1991, especially when we started using anti-CD3 antibodies. That is, anti-CD3 is anti-T lymphocyte antibodies. When they disrupted or ruptured the T lymphocytes, they released a lot of cytokines that resulted in a sudden death or a lot of other manifestations. That's where a concept of a perception of a term called probably cytokine release or a cytokine secretion or excess of cytokine secretion could create. But that was conceptualized into a clear-cut term called as cytokine storm, where in the one of the earliest article published by Ferrara and few other groups, where they used a first time the term cytokine storm. That's where they start acute GVHD. Can it be considered as a cytokine storm? Over 3 decades from its first descriptions, lot of other diseases got into the same group. We started calling as cytokine release syndrome, which we normally use when we use immune cells disruption. For example, if I use anti-B cells, they can also produce cytokine release syndrome. When we use anti-T cells like anti-CD3, they can release cytokines and it's a cytokine release syndrome. So also chimeric antigen receptor, CAR T cells, and lot of varieties of immune interfering mechanisms are utilized. One may end up in cytokine release syndrome. When it is infection, we use term sepsis. We have hemophagocytic lymphocytosis, HLH. You have anaphylaxis, wherein immunoglobulin E triggers mast cells and release of a varieties of what we otherwise used to call slow-releasing substance, which are now which we have understood as cytokines, can result in anaphylaxis, GVHDs, ARDS, and finally SIRS. You know, sometimes sepsis and SIRS are interchangeably used. Should we put all this into a one single syndrome called cytokine storm? I think my next speaker is going to explain in detail that why it may be right, may not be right to put these definitions into one single basket. So there are varieties of conditions which can trigger cytokine storm. We can classify it as a primary or a genetic or a monogenic disorders like familial HLH, related perforin pathway genetic defects, X-linked lymphoproliferative disorders due to deficiency of varieties of genes. We have immunodeficiency and several autoinflammatory syndromes. Infections can trigger. We have viral diseases. Most commonest is herpes viridase, especially EBV and CMV are notorious to trigger that. We have SARS-CoV, which made the syndrome more popular. Of course, though it's considering EBV and CMV, it is relatively less potential in triggering the cytokine storms. HIV, especially in immune reconstitution time, it can result into NSIRS. So similarly, you have bacteria, parasites, fungus, sepsis. And in rheumatological conditions, we have Still's disease, we have SLEs, which can suddenly go into a storm. Kawasaki is one of the IL-6-driven cytokine storm. And you have varieties of other conditions can cause that. In malignancies, especially hematological, can move into a cytokine storm. We have other popular interventions in therapy of malignancy like CAR T cells and BAIT cells can also produce this. Sometimes the cardiac bypass, ECMO circuits, and even the pregnancy, especially when the placenta goes for an abruptio and a sudden immune release of varieties of degradation product comes in and triggers with a danger signal, can result into a cytokine storm. So it's not just that one thing triggers the cytokine storm. You have varieties of varieties of causes, including a monogenic, a single genetic defect, to a multiple reasons which are responsible for the triggers. So that puts us to possibilities that what all can cause. So basically, it's a complex of symptoms which can come. The most commonest, if it is ARDS, it's predominantly in lung. It produces like pneumonitis, pulmonary edema, dyspnea, hypoxia, and ARDS. And in liver, enzyme dysfunctions, hypoalbuminemia, liver injury, acute liver injury, and cholestasis, even can to the extreme of liver failure. Renal dysfunction and renal failure. And vascular and lymphatic system, it can produce multiple cytopenias, coagulopathies, hyperferritinemias. And if you look into the cytokines like rice cytokines, you can see progressive endothelial damage resulting in capillary leak syndrome. These are the conditions where one can look into the varieties of vascular lymphatic features. Nervous systems can have confusions, delirium, aphasia, and seizures. And a constitution feature, usually fever, anorexias. Heart can have tachycardia and cardiomyopathies. And rheumatological systems like vasculitis, arthralgias, and arthritis, rheumatological systems you can see in manifestations. And usually general gastrointestinal, even to an infarct, you can see in the gastrointestinal skin, you can have multiple rashes and a generalized edema. In a patient of a sepsis, in a patient of an infection, in a patient of any conditions, if you start seeing a slow gradual edema with a gradual progressing into distress, one can consider a possibility of a cytokine storm or a moving into one of the list of conditions which we considered as cytokine storm. So what exactly is the mechanism? See, for example, when there is a potential trigger, as I said, the smoothest way is, and the best way an immune system should have responded is, a potential trigger when it sends the dangerous signals like viruses, bacteria, or bacterial product, or some inciting triggers, we expect it to activate some of the innate system like macrophage, monocytes, and neutrophils. They in turn sends the signal, which is to be well balanced by activation as well as a negative regulations. When it, in the beginning, we expect it to activate, release the cytokines like TNF, IL-18, and IL-beta, and various other chemokines, accumulate the cells that are required for the function. Simultaneously, we are expecting them to release cytokines like IL-10, counter-regulating TGF-beta, and also counter-regulating receptors like TNF receptors, IL-1 receptors, which are also secreted into the circulations, which is expected to antagonize, including Treg cells and few of the mesenchymal cells, downplay or regulates the spillover effect, as well as the revamping and bringing down their impact, especially what we otherwise call and collateral damages. They are expected to impact on or impair on those collateral damage. So balancedly increase the fight against the cells, against the inciting trigger. If that doesn't occur, and if there is a continued prolonged activations, MAP kinases, NF-kappa-B, JAK-START pathways, mTOR pathways gets activated, as a consequence of which you may result in a cytokine storm or an acute systemic inflammatory effect, which can result in multi-organ failure. If not handled, it can result in death. So that's how you can see that if you use glucocorticoids, you can prevent NF-kappa-B pathways and balance out a problem of prolonged activation. JAK inhibitor, which was used even in the cytokine storm, if you remember, it was proposed to be used both tofacitinib as well as baricitinib with reference to COVID cytokine storm, where it can prevent JAK-STAT3, which is induced as a trigger pathways to develop into a regulate the cytokine storm. mTOR pathways, we have sirolimus, not much were used, but there were a few smaller trials which were used in the during the COVID pandemics. So, however, by blocking these effects, one can work on that. So this is how the pathway is. We can say that it's an unexpected, sudden storm, which is a response more than what is anticipated. So, but one of the major problem is the pathway is not as simple as we can look at it. We all know that immune system, for varieties of reason, has multiple pathways, also has multiple players. Just for an example, T helper cells, just to make you understand how difficult for us when you're working on a simple single term called cytokine storm. Those cytokine storm looks simpler. You have that there could be 5 different pathways through which a cytokine storm can happen. If it is only Th1, T-bet cells, it is predominantly driven by IL-2 and IFN gamma, recruits macrophage dendritic cells, is said to be one of the mechanisms for HLH and those pathways. Similarly, you can have Th9 pathways where it triggers mast cells, mast cell degranulation, resulting in the mast cell degranulation kind of clinical presentation. If you look at Th2, it's eosinophils and basophil recruitment, along with trigger of mast cells, can result in a similar anaphylaxis kind of things. Th17 trigger predominantly drives neutrophil and neutrophil actions, which in turn can result in varieties of skin and other clinical manifestation. Cytokines and T lymphocytes, which are, if triggered badly, especially happens in viral infected cells, which is one of the reason what we say in hepatitis B's or hepatitis C, acute hepatic necrosis which occurs, where cytotoxic T lymphocytes can literally damage the entire liver and result in the patients moving into the acute hepatic failures. So you can see it's not a single common pathways. I can't just think of, just use, of course, it's a cytokine storm, use anti-TNF, use anti-IL-4. I mean, it's not just a common pathways. There are multiple pathways. And the clinical features sometimes may mimic so closely each other, we are unable to differentiate just based on the clinical feature what could be the probable cytokine which is dominantly driving. I mean, that's one of the reasons why we are still unable to completely grasp or hold a grasp over the cytokine storms. So this is just a list. I mean, we are running short of time. It's just a list to give you a series of the cytokines. We have starting from IL-1 to interferon gamma. We have TNF, GM-CSF. Similarly, you have many chemokines. And these are all the soluble mediators in cytokine storm, which they are triggered, can result in the cytokine storm. So it's not a single cytokines. It's not few cytokines. The cytokines are multiple, can trigger the pathways, resulting in different manifestations, but manifestations sometimes be so similar and may not be possible to differentiate them. So there are, as I said, there are varieties of trigger. You can just see, for instance, if it's a CAR T cell therapy, usually macrophages are the main mechanisms. IL-6 and interferon 1 beta are the responsible factor. At least since you know about them, you can use interleukin-6 antibodies and glucocorticoids. If you come to bacterial sepsis, which is one of the commonest reasons, which is still one of the syndromes in intensive care units where the death and mortality across the globe is quite high, and what dreads any physicians who are in intensive care, we are still unable to tackle it because it's have heterogeneous and multifactorial drivers. So that being the case, currently what we do is we just use antibiotic, control the infection. We have tried steroids, we have tried anti-TNF, we have tried anti-TGF beta. Most of them are for that. Many of them didn't yield of a much successful therapies. When it comes to EBV infections, if we are sure it's a EBV infection, which is either presenting as HLH or any other cytokine storm, B-cell depleting therapy and glucocorticoids can be used because you know the pathways and mechanisms. So whereas in COVID-19, we were unable to justify the drivers, but however, glucocorticoid was a relief for most of us. Though we tried anti-IL-6, we did use JAK inhibitors, but they were of some help. But when it comes to monogenic, I can tell you we are all are more successful because we know the trigger factor and we know the mechanisms with which we can really work it out. For instance, autoinflammatory syndrome, we know specifically anti-TNF and anti-IL-1 in different groups we can utilize. So the major challenge that we have with reference to these cytokine storm is multiple. For instance, here the green one is the one which shows an approved way of handling it. The blue one is not very sure whether it is useful or not. For example, in sepsis, we tried anti-AL1 and anti-TNF, not very successful. In COVID, we tried several. The JAK inhibitor was the one which was supposed to be successful. IL-1, IL-6 and TNF were not really, didn't show much good results. And if you come to juvenile systemic JIA, Still's disease, we could see anti-IL-1, IL-6 and JAK inhibitor to be really effective, whereas the anti-IL-18 was not that useful. So similarly, in adult Still's, we have only anti-IL-1, IL-6 still no trials are there. JAK also we don't have. When it comes to HLH, we have IF and gamma U to be useful. JAK inhibitor, in my experience, it is useful in a few patients. In few patients, it was not really useful. So you can see that based on the probable cytokines, we can think of utilizing some of the anti-cytokine strategies. Few are successful, few are not. The reason for the failure, why are we not successful, is sometimes we feel that it may be too late to intervene, which may not help, especially in sepsis. Normally, we start thinking about using corticosteroids or using the anti-TNF strategies or any of these cytokine strategy, probably in too late in the sepsis. In sepsis, we always say after a set point of reversibility, if it will never move backwards. So if you want to too early to intervene. I mean, I don't think anybody will agree to start a steroids or anti-TNF when you are sure there is a big sepsis sitting, because you don't allow to interfere in the immune responses. We are not sure in varieties of conditions what is the optimum point where we can interfere. And in many of these cytokine storm, there are multiple players. Manifestations and profiles of cytokines are not enough to guide and differentiate between different components. However, it's not a total failure story when it comes to cytokines. Monogenic diseases, we are successful. I showed the green slips. And AIRD, autoimmune rheumatic disease, there are planned strategies which can really helpful. So we have a long way when it comes to cytokine storm. Real understanding can save a lot of life, especially from the intensive care units as well as from the general care. If I can pick early before the rolling down of the patients, it can definitely help and save a lot of patients. Thank you very much for patience hearing.
Thank you very much, sir. That was an excellent session. Dr. Chandrasekhar, sir, thanks so much. Sir spoke about cytokine release syndrome from the physician prospect. Dr. Gansham, sir, anything you would like to say? Then we go to the pediatric part.
Yes, ma'am. It's a wonderful talk, very lucid presentation, and whole spectrum of cytokine storm, sir has already told. And in physician dilemma is always there, sir, like optimization, when to start the immunomodulator drug. Like most of the patient will come with sepsis. We don't know, we should diagnose early and start early treatment, or we should wait for antibiotic to respond, then we start. So is there any benefit, sir, with getting like HLS 2004 criteria can we use, or very high ferritin can help patient who is having hyperactive inflammatory response? What is your comments on that, sir?
No, I mean, the ferritin and other things can guide you to some extent, but they still don't have enough evidence, both from the trials or from the study, that it can give you a foolproof evidence. Because sometimes just a viral infection can have a high ferritin, even without a cytokine storm. Yes. And so that being the case, it's always a difficult scenario. So as I put it straight in my last slides, we are still moving around to figure out what's the best way to pick and choose, and what's the right time to start them. Because this especially we face when it comes in the being a rheumatologist, when we treat, we sometimes always feel that, should I really withdraw the immunosuppression in a patient who gets an infection? I mean, that's still an unsettled story, because many still say that you bring it down, but don't totally remove the immunosuppressives, because patient may go for a cytokine storm, because they may go for a reconstitution syndromes. So it's always a tough dilemma. So we were just trying to work from my center, because this year we had a huge number of dengue patients who had come because of the bad epidemics we had. So we are trying to work on those patients. That what really we could see was most of our patients were on immunosuppressions. I never had, out of the 70 patients which were screened, going into the dengue hemorrhagic fever or cytokine storm. Was that the immunosuppression the patient was on, did it saved? I really don't know. I think we need to compare with few other general things. So none of these markers are really very helpful currently, as we know.
Yes, sir. This time we have, sir, 2 dengue patient with HLH-like syndrome, like a cytokine storm. We did give steroid after 4-5 days, getting all the tests done. So we tried to use HLS 2004 criteria, and luckily that patient survived, sir. So yeah, you are correct, sir. Dengue patient this time do have this cytokine storm-like picture. Few patients, sir. Yes, ma'am. Dr. Manjula.
Thank you, sir. Our international faculty, Dr. Ramanan is there, Professor Ramanan. So we'll start the pediatric portion, and if there are any queries or questions on the platform, we'll take after that together, right? So we have the pediatrician perspective on cytokine release syndrome, SIRH, MODS, and HLH. So to chair this session, we have a very eminent pediatrician, senior pediatrician with us, Dr. Dhanamurthy, sir. Sir is a very senior and well-known pediatrician from Bangalore. He's a president of IAP Bangalore since 2011, president of IAP ID chapter in Karnataka 2014, the fellow of Indian Academy of Pediatric 2016, JT Chief IAP Action Plan for Coordinator 18 and 19, CIAP Chief Election Officer 2020. He's been involved in a lot of HOPE program, several programs of IAP. So a lot of academic and the educational interest in sir. Sir, over to you, sir. Thank you very much for accepting the chairperson, and I request you to kindly take over and conduct the session. Sir, over to you, sir.
Thank you, Dr. Manjula, for your kind introductions. And indeed, I'm highly privileged to chair this occasion, this from the pediatric aspect about a cytokine syndrome. And we have none other than a person who has created a wave during the COVID-19 about a cytokine syndrome, because his talks everywhere has gone like a stormy talks we heard earlier also. And we are in fact privileged to have him again to speak about Professor A.V. Raman. It takes a big list of things, and he's got innumerable papers presented about the immunology. He is a pediatric rheumatologist working at the Bristol Royal Hospital for Children. He is a joint lead for research in the Bristol Royal Hospital. Again, he is a professor of pediatric rheumatology, University of Bristol, and he was a earlier elected fellow of Academy of Medical Science for UK in 2023, and he is a medical advisor for Oration. And we are proud to say that he's been awarded the British Society of Rheumatology Innovation in Clinical Practice Award, and also awarded the University of Bristol Vice Chancellor Health Impact. The award goes on, and he has published more than 250 international articles, and he has authored many topics, and he's been one of the editors of 5th edition of Oxford textbook on rheumatology, widely recognized. And he is a lead pivotal trials of tocilizumab and baricitinib in COVID-19, as I told you earlier, and also part of the pediatric steering committee of the recovery trial. And he is also closely associated with us in India, especially his work with our legend, Professor S.P. Balasubramanian of Chennai, and we heard a lot about him. And now he's going to talk about pediatric aspect of cytokine syndrome. As they say, what's in name? It can be named as hypercytokine syndrome. It can be named as hyperferritin syndrome. It can be named as HLH. It can be named as cytokine release syndrome. Like that, various names are there. Again, they all being a spectrum of same pathogenesis pathology, but of different etiological aspects. And to deal in pediatric and how to resensitize this aspect, and to pick up this from the pediatric aspect, I request Professor A.V. Ramanan to throw light on that. Over to you, Dr. A.V. Ramanan.
Thank you very much for that kind introduction. I'm just going to start sharing my screen and then start projecting. In the interest of time, that's an extremely generous and kind introduction, and I'm really pleased to join you this evening. Firstly, some apologies if there's a bit of overlap with the previous speaker who gave you a fantastic overview. I apologize, we didn't exchange slides. But what I'm going to try and talk to is, many times you go to infectious diseases meetings or you go to intensive care departments, and you will hear people use terms which I've put in this slide, such as this patient has got systemic inflammatory response syndrome or multi-organ dysfunction syndrome. And usually the nomenclature doesn't change anything. What we are really after is where the nomenclature enables you to change the therapeutic direction. Now, some of us, me included, have been working on this area for 20 years, but we have a lot more emphasis on this condition, as with lots of things in life after COVID-19. Cytokine release syndrome always existed. It's just you needed a pandemic to bring it to the attention of the wider public. And never before is something more important when the New England Journal of Medicine decides to run a review article like it did in 2020. And I think hemophagocytic syndromes or this sort of hyperinflammatory syndromes have long existed. But COVID-19 really put a spotlight on it. And you've seen some of the features of this storm or this syndrome in the previous speaker's slides. So it's really an amalgamation of multiple things. We in pediatrics, and for that matter, even in adult medicine, you will see leukemias or lymphomas first presentation in the form of a hyperinflammatory or a hemophagocytic syndrome. You can have already, as you've heard, cytokine release syndrome, which is a really specific term associated with CAR T cell therapy. We know that in children and adults presenting with acute respiratory distress syndrome, which is really a descriptive term, not a diagnostic term, you can have features of hyperinflammation. Certainly, dengue, flu, EBV can all give you features of hyperinflammation, as does rheumatological conditions, which has already been alluded to by the previous speaker. What do you see? Because most of us are clinicians, and I apologize, it's late in the evening for you, and I'm going to show you some immunology. Showing immunology at any time of the day is bound to put people to sleep, and the last thing you want to do is do that in the evening. But really, most of us are pediatricians or internal medicine physicians, and what we look for in clinic, you can have neurological features which can either be subtle in the form of some speech slurring, or it can be frank seizures. You excuse me, you'll clearly have cardiorespiratory symptoms, and this can be tachypnea, hypoxia. You can have hepatosplenomegaly, but it's really in the blood test you're really going to find features of this. And what you're looking for is a pancytopenia, or at least a two-cell line cytopenia. You're going to have a coagulopathy with really elevated markers of clotting, and you may have a DIC-like picture. And I'll come back to how this is going to help us in the clinical medicine and in the laboratory medicine to diagnose and how we can direct our treatment. You've already heard Dr. Chandrasekhara refer. So when you're confronted with sepsis, you go with antibiotics. But if the appropriate antibiotic isn't making your patient better, many times, and I'm going to show you some data from UK, people with sepsis die and they're labeled as sepsis DIC, when probably immunomodulation would have saved their lives. EBV HLH is the best example. We recognize that a tiny proportion of EBV patients will get a hemophagocytic syndrome. The vast majority will recover with very minimal symptoms. And for this tiny proportion, rituximab and steroids can be both curative as well as life-saving. And we know that in multicentric Castleman's disease, particularly in multicentric Castleman's disease, which has got a viral trigger with HHV8, we can give B-cell depleting therapy. Sometimes you can give IL-6 based therapy for multicentric Castleman's with tocilizumab, but rituximab, which depletes B-cells, is a much better option. And of course, in COVID-19, as has been mentioned, we've now pioneered that steroids, baricitinib, and tocilizumab can be life-saving, really. So the context is a condition which we in pediatrics have recognized, a 1 or 2 year old child presenting with pancytopenia, sepsis-like picture, who probably has an underlying defect in innate immunity. We now know that these patients can be treated with HLH 2004 or protocol, or the which gives you steroids, which will use intrathecal methotrexate and etoposide. And of course, we have novel molecules such as emapalumab, which blocks interferon gamma. But the key condition most of you are going to deal with in your life is when you have secondary HLH. And as has been mentioned, and we have done some work in India, both in Chennai and Calcutta, which in the interest of time, I'm not showing, but some children and some adults with dengue will have features of a hyperinflammation in whom steroids certainly help. Of course, the WHO guidance currently says do not use steroids. The randomized control trials done so far are very poorly conducted, and we are currently about to start a trial of anakinra in Vietnam with my colleague Sophie Yacoub in dengue in adults and in children, where we're going to take children and adults with severe dengue using a set of markers which we have pioneered already in COVID-19, such as D-dimer, LDH, and ferritin, and we're going to give them anakinra. And you've already heard about autoinflammatory disorder, which is not the context here because it's really rare. But in idiopathic multicentric Castleman's disease, again, we know you can give rituximab or tocilizumab. And you've already heard a lot about this. The picture of CAR T-cell induced cytokine release gives us the immunological framework for understanding what happens. We now believe, if you take dengue as an example, a lot of people get exposed to dengue, but a tiny proportion becomes significantly ill, and an even tinier proportion get life-threatening illness. What is it about these patients that makes them get life-threatening disease, whether it's with dengue or with EBV or some other viral, bacterial, or parasitic trigger like Leishmania we know gives you HLH? And it's probably they have an underlying defective innate immune system. They may not be perforin mutations which present in the first year of life. They may be polymorphisms with the right second hit, which might be the right virus for that patient, or the wrong virus, for example, or a parasitic infestation, they get persistent antigenic stimulation. As has been mentioned before, we release cytokines in order to deal with the infection. But when you have unregulated release, because your immune system is perceiving persistent antigenic stimulation, then you will have this exaggerated release of cytokines. And then it's not the infection which causes death, but it's the immune response which leads to death. And why do we talk about it? Because we can now do things which will enable these patients to live. And IL-1 inhibition with anakinra, which I'll finish off, can be life-saving for a lot of these patients. And I know it's not easily available in India, but it's something which, in the interest of scientific discussion, I'm going to touch on. For certain specific conditions, you can use IL-6 blockade. The rest of those are really not for routine clinical care. So Dennis McGonigal and I, at the start of COVID, published this what we call immune cartography of what in rheumatology we call macrophage activation syndrome, which is essentially another term for a hyperinflammation. And in order to understand the varied clinical picture, we have the pediatric patient who presents in the first year of life with classic hemophagocytic syndrome, primary hemophagocytic syndrome, and they'll have a pancytopenia, sepsis-like picture. And if you marrow them, or if you do a splenic or a liver biopsy, you will see hemophagocytosis. But in dengue and certain viral infections, you can have a coagulopathy picture with activation of the endothelium, which gives you that hemorrhagic shock syndrome. And sometimes with bacterial sepsis, the presentation is going to be in the form of a multi-organ dysfunction syndrome. In CAR T-cell therapy, you will get a much more homogeneous cytokine release syndrome associated with treatment. So really, in the field of immunology, you can have both immunodeficiency presenting as hyperinflammatory syndromes, and you can have gain of function immune defects also presenting as hyperinflammatory syndrome. So the world and the way we understand the complex interplay between innate and adaptive immune system has really changed radically. And I'm showing this to you because this is a condition which presents in the first year of life, which presents with enterocolitis, sepsis. Most of these children die. You can have some lymphoblastic leukemias and lymphomas present with hemophagocytic syndrome. Lupus with macrophage activation syndrome is well recognized, and I think there's a session later on. And of course, some primary immunodeficiencies, such as perforin defects, as well as other primary immunodeficiencies, can also present with primary hemophagocytic syndrome like picture. And the reason we go on and on about this is because we can now block IL-1 with anakinra, we can block IL-6 with tocilizumab, we can block TNF with a host of molecules, and we can block gamma interferon now, which is a pivotal cytokine, with emapalumab. And there is a blocker of IL-18 called tadakinib alpha, which certainly works in certain conditions. And IL-18 is a key cytokine in hyperinflammatory syndromes. So as pediatricians, this is the cartoon we recognize. We know that you have primary hemophagocytic syndrome patients who will not live unless you diagnose, treat them with HLH 2004 protocol, and then do bone marrow transplant. And then you have virus or infection associated, which is what most of you are going to encounter in your general medical or general pediatric practice. And the criteria, which is rather narrow, is you must have fever, splenomegaly for hemophagocytic syndromes, a 2-cell line cytopenia. The last three is fairly useless. Nobody is going to get soluble CD25 in the real world. Very few of us can do NK cell activity. So I'll tell you how we can use what is easy to access and how we can diagnose. So you may ask me, how common or uncommon is hemophagocytic syndrome in routine pediatric care? So this is an audit we did, which we haven't published yet, which was presented a few years ago. So we looked at all the key big children's hospitals in UK, and we said we'll go to the biochemistry labs and ask for all ferritins about 10,000, because this might be a cheap and cheerful biomarker. And this might be your average patient, a 3-year-old boy presenting with what looks like a viral or a bacterial infection, but rapidly becomes unwell with renal impairment, pancytopenia, elevated CRP, and a ferritin close to 10,000. So we said, if we can have 4 of the 5, which is universally available, and these 3 which is not available, and a ferritin which is more than 10,000 has now been shown to have a very high specificity. So really, if you've got a ferritin of more than 10,000, you're talking some form of hyperinflammatory syndrome, and you need to consider what you do. So what did we find? We found over a 3-year period between April 2014 and March 2017, when we looked at all ferritins about 10,000 in the big 8 children's hospitals in UK, and said that we'll only go for 4 of the 5 because most of us can't access, do a biopsy of the marrow or access NK cell function in time or soluble IL-2 receptor. So we identified almost 100 patients in this period. These are pediatric patients, a slight male preponderance, and you can see almost half of them have been admitted to the pediatric or the neonatal intensive care. And the ethnicity distribution is similar to what you'd expect from the population prevalence. But really, this is the key. I want you to focus. Only half of these patients, even in a very developed healthcare system, were thought to have hemophagocytic syndrome and considered so by the treating team. In a third of the patients, hemophagocytic syndrome was not considered. If something is not considered, then it's not going to be appropriately addressed in the form of therapeutic intervention. And the mortality in this group is very high. A third of the children with a ferritin of more than 10,000 died. So, and the death rate is much lower if the treating team considered the possibility of HLH. So what am I leaving you with? I'm saying that there are patients, adults and children, in different adult and pediatric intensive care units who will have ferritins which are high, who are being labeled as sepsis, and appropriate immunomodulatory treatment is not being considered. So in children with fever, cytopenia, and multi-organ involvement, check the ferritin and think of it. So you will immediately ask me, ferritin is an acute phase reactant. Now, Joe Carcillo from Texas has clearly shown, for those who are interested, that hyperferritinemic sepsis is very different from sepsis without hyperferritinemia, giving us a valuable window of which sepsis patient should we immunomodulate and who we should just manage with supportive care. We published this a long time ago because most of us are busy clinicians. You want a simple biomarker. Here's my suggestion. If you have a child with fever, cytopenia, coagulopathy, not getting better on appropriate antibiotics, check the ferritin. If it's less than 500, you're not dealing with a hyperinflammatory syndrome. If it's more than 10,000, it's extremely likely you're dealing with a hyperinflammatory syndrome. You need to consider immunomodulatory. If it's in the middle, you have a chance of doing the other markers. But really, anything above 5,000 in our own work is considered highly reflective, with the receiver operating characteristics being as close to levels of 10,000. So what can we do? In the 90s, there was a randomized controlled trial of anakinra in adult patients with sepsis. It showed it was safe, but it wasn't statistically significant. The problem with that trial was they didn't stratify the patients. So when the data was reanalyzed 25 years later, and the data was reanalyzed in looking at which patients had hyperinflammation with ferritin and DIC picture and who didn't, they found that in sepsis, if you give anakinra and IL-1 blockade, you had better survival if you had features of macrophage activation syndrome or some form of cytokine release syndrome. So this reanalysis meant that actually even in sepsis, there are a cohort of adults and children who will benefit from immunomodulation. The most common immunomodulator we use is anakinra because it's extremely safe in sepsis. And of course, access to it is pretty limited in several parts of the world. And what they did in this reanalysis was divide the sepsis patients into those with hepatobiliary dysfunction and DIC and those without hepatobiliary dysfunction or DIC. And they found, as I mentioned, treatment with anakinra was significantly improving survival rates in those with what we consider as surrogate markers of cytokine release, which is hepatobiliary dysfunction and a picture of DIC. So you can see 65% survived compared to 35.3% in the placebo group with IL-1 inhibition, which in this case was intravenous anakinra. So what I want to leave you with in this very short talk, I've been known to give this lecture over an hour or 2 hours, is it doesn't matter what you label it. But if you have a sepsis patient who's got a hyperinflammation or whether they've got multi-organ dysfunction, you need to get the terminology right so that you can immunomodulate. It's not about what you put in the notes. It's about how you treat the patient. And for those who have an infectious diseases background, we published this in PIDJ, the infectious diseases. So we said, look, if you have a fever and ferritin and cytopenia, this is what you do. I leave you with this as my final slide. I think I've sought myself a good 2 minutes, finished exactly on 15 minutes. So thank you very much. I think there are no questions. I'll leave with this. Thank you very much for inviting me and enabling me to share my experience. Thank you.
Thank you, sir. Dr. Gnanmurthy, sir, you are on mute, sir.
Yeah, thank you, Dr. Rahman. It was, in fact, I would say it's a stormy talk, and to cover entire stormy hyperkinetic syndrome in just 15 minutes, it can be only possible with person like you, Dr. Professor Raman, and definitely brought out a very clear aspect. And also you sensitize we pediatricians when we should look for a child going for hyperkinetic syndrome. So it doesn't matter what you name them, as you said rightly, but what is important is how early you pick up, because early you pick up, you can tackle it much better. And you brought out very clearly an algorithm, based on the picture. So suppose we take a prototype of dengue fever, if it doesn't resolve the way it has to resolve, and if it's taking a little more long, then one should always think something is happening with this, and you always go for CRP, serum ferritin, and IL-6. With this, and you apply your algorithm, definitely will be able to pick up the child going for cytokine syndrome, and wherein you can always make use of the best medications and save the child. And thank you very much, Dr. Raman. And it was nice of you to be with us, and really overwhelmed with your presence, and given a fantastic talk on cytokine syndrome.
Thank you very much.
Very much, Professor Ramanan sir. Thank you so much. We will move to the inaugural session and the keynote address. We have Dr. Soumya Swaminathan already joined us. So we will start the inaugural function. Can I have the organizing chairperson CV?
Yeah, I'm there already, Manjula.
Yes, sir. Dr. Muruganathan sir, Dr. T.S. Ravindra sir, Dr. Jagdish Chennappa sir are our organizing chairperson. Dr. Muruganathan sir, everybody knows, very, very eminent doctor known across India and worldwide. Sir is the immediate past Governor of American College of Physicians, Emeritus Professor of Tamil Nadu, Dr. MGR University, Dean of Indian College of Physicians, past President of Hypertension Society of India, Association of Physicians of India, and past President of Tamil Nadu IMA, and past Dean of IMA CGP. Sir is the founder, member, and chairperson of the Scientific Committee for Fever Foundation and organizing chairperson. Next slide. Of FEFCON. We have with us Dr. T.S. Ravindra sir. Can I have the next slide, please? Sir is the head of Department of Medicine at Mallige Hospital, Bangalore. He has expertise in internal medicine for more than 2 decades, and his special interest is intensive care, and several publication journals and peer-reviewed journal, contributed several chapters, and he's been with the Fever Foundation since the inception. He's organizing chairperson for FEFCON. So welcome to you, sir. Then we have Jagdish Chennappa sir. Sir is the cluster head of Pediatric at Manipal Group of Hospital, Bangalore. He's a past president of Respiratory Chapter of Indian Academy of Pediatrics, CEO for Medtrain, Bangalore. He's a consultant at Child Central Clinic, Bangalore. He's involved extensively in teaching undergraduate medical student, postgraduate student, and nurses. President of IAP at 2007, examiner for MD Pediatric from 2007 onwards. He's organized several conferences, including Respicon, and he does a lot of certificate courses in pediatrics as well as allergic courses, and he's been with us as a founder member of Fever Foundation. Sir is also COVID-19 Pediatric Task Force for Karnataka government, and he's organizing chairperson of FEFCON. So welcome, sir. Welcome to Dr. Muruganathan sir, Dr. T.S. Ravindra sir, Dr. Jagdish Chennappa, Dr. and Madam is Dr. Soumya, Madam is there. Over to you, sir, Dr. Muruganathan, sir, to conduct the inaugural and the key session.
Thank you very much, Dr. Manjula. It is in fact, it gives me great pleasure to be there in the inauguration to introduce my good friend, Dr. Soumya Swaminathan. Last time also the Fever Foundation, we tried Soumya, and she was in Geneva, and then she was supposed to inaugurate. But some other we missed, and she always comes for all scientific programs. And this Fever Foundation, I think Maya was talking about how we started. In fact, one more history, Maya, I think I should share with you, because you may not know. Before this Fever Foundation, we had pain. The supported by Micro Division, we had pain program symposium all over India. We conducted more than 90 programs. Praveen was there. Even Manjula was not there. So from that pain only, we started this fever. So Maya came only after pain. So we had pain, and then we started this along with you as fever. And I'm glad Dr. Soumya has accepted to be the chief guest and going to inaugurate. You know, Soumya, all of us, the world know who is Soumya and her service during COVID. Everybody knows, every citizen in the world knows. She is the chairperson of the MS Swaminathan Research Foundation. Recently, we lost Professor MS Swaminathan, his daughter only Soumya. He is the former chief scientist of World Health Organization. He is the deputy director of ICMR, WHO, secretary to Government of India Health Research, and coordinator of the UNICEF World Bank Special Program for Research and Training. She has published more than 500 peer-reviewed publications and book chapters. She is also fellow of the US National Academy of Medicine, the Academy of Medical Sciences of the UK, and fellow of all science academies in India. Several honorary doctorates, including from Karolinska Institute, EPFL, Lausanne, and London School of Tropical Medicine. She is also adjunct professor of the Karolinska University in Sweden, Tufts. She is also WHO inaugural chief scientist, built the science division with a focus on research, quality assurance of norms and standards. Key role in setting up of COVAX with focus on equitable vaccine distribution to low and middle income countries. So she was one of the strong pillar during COVID, and she did a lot of work on vaccines and prevention. And we are very proud that Soumya was from our area. So with this introduction, I would like to request Dr. Soumya to give the keynote address and inaugurate the conference. Thank you. Over to you, Soumya.
Thank you very much. Thank you, Dr. Muruganathan. And so nice to see many of you that I have not seen for a while, but lovely to see you all on the screen, if not in person. I think this is a great idea that you have this kind of a conference. In fact, it's the first time I was hearing about it. And Manjula actually called and told me what it is, what is this PEPCon, and how you're actually conducting it. So I think it's very innovative to do it like this, in the evenings, and then to really have the cutting edge work being presented. So it's also a very important subject, because obviously it's one of the most common symptoms that people have and that people present with. And it's also probably something that is most mismanaged, or either over or under diagnosed and under or over medicated. And all of us will have in our experience a lot of instances where that happens, and where an appropriate workup is not done, and where ultimately the patient suffers. I myself have worked on tuberculosis for a large part of my career, so I know how much both under and over diagnosis of TB happens, and how little still the recommended diagnostic pathway is actually followed. Even now, after so many years, and the WHO actually recommended molecular diagnostics for all people with suspected symptoms of TB several years ago. They made that as the gold standard. And yet in India today, less than 25% of people who have TB related symptoms actually have access to a molecular diagnostic as the first or upfront test, of course. So that means still smear microscopy is being relied on. And later on, once the patient is smear positive, then they do a diagnostic molecular test to see if there's resistance. But that's not enough, because you're going to miss a lot of cases. We know that smear microscopy is less than 50% sensitive. Similarly, I think when you look at other causes of fever, when I was in the ICMR, we used to have these outbreaks of encephalitis in Gorakhpur amongst young children, and every year, literally thousands of children would die without diagnosis. And people just believed that it was either Japanese encephalitis, something else. I remember going to those wards in the Gorakhpur hospital and really being horrified to see the number of children admitted in the ICUs, and just going around there and asking the history from each of the parents. you could easily tell that some were acute, some were subacute. There was a case clearly which was TB meningitis, which was also there in the acute encephalitis ward. And there was complete lack of any diagnostic workup. So we put in place some studies and systems, basically again focusing on sort of metagenomic analyses of the CSF so that we could identify, there were multiple options obviously of which pathogens could cause this type of syndrome. And then we were able to actually come up with the top 5 causes of acute encephalitis syndrome, also probably the top 5 causes of fever in that area. And the number 1 was scrub typhus, which was not on the list of any physician in that area. Very simple treatment with tetracyclines, but obviously if you don't think of scrub typhus, you're not going to treat it. And I think that's probably one of the infections that we are still underdiagnosing across India today, because studies have shown when you look for it, you find it. So over the last few years, it's very good to see that these cases of acute encephalitis syndrome have significantly come down because of the treatment protocols that were put in place, so that at the primary healthcare centers, the doctors are giving tetracycline to children who are presenting with fever, particularly in those months. I think it's around June, July, August is a sort of peak period for that. So it shows that when you use appropriate, you use a science-based approach and address the problem, use tools and technologies like genomics, metagenomics, etc. Today we have access to that, especially after COVID. So much expansion of genomic capacity in our country and in other countries. We should be using much more of that, I think, to look at our infectious disease epidemiology, both existing pathogens, emerging pathogens, re-emerging pathogens, and be prepared, of course, for detection of any new pathogens that might come, because we know that the next pandemic is not a but. It's not an if, it is a when is going to be the next pandemic. It could be in 2 years, 5 years, 10 years, 20 years. Nobody knows. There will be another virus that jumps from an animal host into the human. So we will have more and more zoonotic infections. And so I think what is important is the approach that we take, the resources and the infrastructure that we create, that we put in place protocols, we put in place mechanisms to investigate, but also I think really important is the data, the research, the evidence generation and sharing, and the creation of these type of bodies, of physicians, of pediatricians, who can take up these issues, address them, and come up with recommendations. Teaching, training, CMEs, very, very important. But also, I think, engaging with the government, with the ICMR or others, wherever there is an issue which needs to be addressed at a larger level, then I think groups like this could bring the attention of agencies like the ICMR to put in place studies. And then finally, I think there's a lot of opportunity in India, again, to do research across hospitals, whether in the private or the public sector. I think we're not really leveraging the strengths we have, which is the medical expertise that we have in the country and the huge numbers of both very well-trained doctors, but also of a huge number of patients, of the heterogeneity that we see of clinical syndromes and presentations, both in the outpatient and the inpatient and in the ICU and so on. So having groups a little bit formal, could start with informal, but I know that there are now many groups like that in India of committed physicians who not only want to treat patients, but who also want to add to the growing evidence base to sort of set up registries, set up very simple data collection platforms for a common problem that is being seen across multiple sectors, multiple geographies. And through that, there are many examples where just through that, putting in place those systems to collect data over a period of time, you come up with insights, and then that can then lead to guidelines and recommendations, and ultimately be contributing to improving the health outcomes, which is a goal that I think all of us have as physicians. So I would love to see more of that kind of initiatives. Could be supported by the IMA, the IIP, etc., but need not be. The ICMR does support a number of such registry programs, but again, there are limitations to what all ICMR can do or fund. And so I think that there are enough resources out there, to be able to put in place these things. So happy to, discuss that at some other point, Manjula. But again, congratulations and very best wishes for this year's FCON. Thank you.
Thank you so much, ma'am. Muruganathan sir, you are on mute, sir.
Thank you very much, Professor Soumya. First of all, I must thank you personally, because once when Manjula called you, you were a little bit hesitating. Then I really requested you again. Then you accepted it. I'm very happy. So I personally thank you for accepting, because this is a huge program, Soumya. More than 35,000 people have registered.
67, sir.
67,000. Yeah, 67,000 people have registered, and everybody is interested in now fever clinic. And
Right.
as you said, the Fever Foundation also has got a fever registry. We are also doing a lot of research, and we would look forward to your guidance and support when we do some research activity or registry or any particular thing you want. You always call me and tell me, Soumya, as we have last week we met in Secretariat, like that we can do some joint program also under your guidance and support, because you being the world figure, you can also get some support from other areas also. We can do so many good things about fever and vaccine. And I request Jagadish Chinnappa and Ravindra to offer a short felicitation for the inauguration. Yes, Jagadish Chinnappa, over to you.
Nice to see you, Jagdish.
Nice to see you, ma'am. And thank you very much for accepting this invitation, because it's a real honor to have you here. We have always been in awe of all the work that you have done, right from the time at the TB Institute and at WHO and during COVID times. And now I think we can take this even further. As Dr. Muruganathan said, we can always look at your suggestion of trying to look at various simple diseases, collecting data, etc. So I think definitely that will be a very good idea, and we should take it forward. Thank you so much, Dr. Soumya, for joining in.
Yeah, now Dr. Ravindra, your felicitation, Ravindra.
Yeah, ma'am, it's a privilege and an honor to have you here. And we thank you very much for giving an excellent lecture. Thank you very much, ma'am. Always remember this. Thank you very much.
Thank you, Soumya. We don't have a physical lighting lamp, but when you approach, when you speak, it throws light. So that is the lighting. So we take it as lighting that way. And your lighting words will inaugurate the conference. And we are privileged to have you. Once again, we look forward to your support and guidance. Now over to you, Manjula, for the next session. Thank you, Manjula.
Very kind of you. Very kind of you. Thank you.
Thank you, ma'am. Thank you so much. It's a very privilege to have you, ma'am. Thank you. Sir, with the permission of all the J, we will move to the next session, which is our prestigious Sri G.C. Surana oration. This oration will be rendered by Professor Dr. G. Narasimhallu, sir. So we have Professor M.K. Sudarshan, sir, who is going to be talking about the pioneer, which is G.C. Surana. Then Muruganathan, sir, will be introducing. so we had also a felicitation, since it's a virtual, so we had a felicitation ceremony which was done, so that also will be shown in this case. So let's move to the GC Surana oration. Can we start the oration, please? So can we have the about GC Surana sir? So can we have Dr. M.K. Sudarshan sir to speak on about the pioneer GC Surana? M.K. Sudarshan sir is a chairman, Karnataka State COVID-19 Technical Advisory Committee for Government of Karnataka, ex-director and retired dean and principal and professor of HOD of Community Medicine from Kempegowda Institute of Medical Sciences, Bangalore. Sir has got extensive knowledge, and he's been the WHO expert for rabies. He has done a lot of work in rabies in India across the globe. And sir has got more than 100 publications in various national and international journals. He has authored several books. And sir also won a lot of awards and accolades. And sir has been our advisory board member, and especially he's supporting us from the epidemiological point of view. Sir, may I now request you, thank you very much for joining in, sir, and may I now request you to kindly talk about the pioneer Sri GC Surana, sir.
Yes. Thank you very much, madam. I think I request RX Events to project the first slide, please. Good evening, everybody, and I am very privileged and personally honored to speak on this occasion about the pioneer and the founder of Microlabs, who was a visionary, whose life is a source of inspiration to all of us. Next slide, please. Karma Yogi, late Sri GC Surana ji, he hailed from Rajasthan. He moved to Bangalore in early 1970s. In 1973, he started the Microlabs in Bangalore that today employs over 12,000 persons. As a firm believer in quality education, he also started Surana Group of Educational Institutions in Bangalore. He has donated generously towards social welfare, and his contribution is immense in the field of education, health, and religion. His strong willpower, phenomenal memory, clarity of thought, bravery of expression, and accuracy of content, backed by a vast humanitarian approach, provided an inspirational leadership to micro group of companies. Next slide, please. Sri GC Surana ji's contribution to society is immense in the field of education, health, and religion. Surana ji believed that quality education should be made available to all sections of the society. Next slide, please. He was inspirational to his family, and his sons now, Sri Dilip and Sri Anand, have taken Microlabs to the zenith of its success. Next, please. So, with this, I conclude this short introduction, and I thank Dr. Manjula and the advisory board of the FAIR Foundation for giving me this opportunity to introduce Sri late Sri G.C. Surana ji, in whose name this oration lecture will be delivered by Dr. Professor Narasimlu on the topic of enigma of pyrexia in SLE. So with this, over to Dr. Manjula, please. Thank you. Thank you very much.
Thank you very much, Professor Sudarshan sir. Really, GC sir is really inspiration to all of us. His life has been really inspirational. Now, may I now request Dr. Muruganathan sir to talk about the orator of today, Professor Narasimlu sir.
Thank you very much, Manjula. It's a great pleasure for me to introduce my good friend, Narasimlu. Narasimlu is a very charming person, always smiling and then very enterprising man. He's also our founder, member of the Fever Foundation. He'll always argue very vigorously, but when we say, please, Narasimlu, accept it, he'll accept it. So he'll go extremes and then he'll come back very cool. He's a very cool personality, very good friend of mine. And he's got a lot of ideas and a lot of, innovative thinking. So sometimes he overthinks. That's why he gets more research-oriented, activities done under his belt in this department. And he developed the department there in his institute. He was fighting for, this department with the that time MCI, and I was also helping him. So now I come to Narasimlu. He's a senior consultant rheumatologist, GVN Medical Center. He is also Professor HOD Rheumatology ESI Medical Center, Super Specialty Hospital, Hyderabad. He is a former professor of HOD, and then he was the examiner for all the rheumatoid and rheumatic, post-graduation and fellowships. He is a past dean of ICP. He is the past president of Indian Rheumatology Association, former assistant editor of JOPI, former president of IACM. He has published numerous papers in various journals, contributed chapters in various updates. He is a recipient of API Distinguished Member Award, recipient of prestigious APLAR Master Award. He has got so many orations under his name: Kolkan by IRA, Srinivasa Oration, Mehta Oration, Sukumar Oration, and Mukherjee Guest Lecture. Incidentally, he himself has initiated an oration in his father's name, and I was the first person offered by Narasimlu to deliver his father's oration in the Hyderabad in the API. He's organized national conference and CME on joint diseases and osteoporosis. Organized departments of rheumatology in NIMS, started DM, I already told you, DIP NB, and fellowship course in rheumatology, first in India. Organized DNB Rheumatology in ESI Medical Center. Member of various professional bodies, former chairman of Association of Physicians of India, and is one of the strong leader of API, and I already told you, founder member of Fever Foundation. As already mentioned by Sudarshan, he is going to talk about fever in the SLE. Narasimlu, we are eagerly waiting to listen to you. Over to you, Narasimlu.
Thank you, Dr. Muruganathan. Many, many thanks.
Narasimlu sir, 1 minute, I request we had actually, since it's a virtual, we had felicitation done separately. So with the permission of the chair, can we run this video and then we hand over the session to Muruganathan?
Yeah, okay, fine, no problem, Manjula.
Right, thank you. So RX event, can you play the video of felicitation?
In fact, Narasimlu, Manjula invited me to come to Bangalore to honor you, but unfortunately that particular day I was not free, but I called you and greeted you. Manjula, I am disappointed. Where is the honoring for Narasimlu? That is the oration, no?
RX event came.
No.
Actually, Narasimlu honored others.
RX event, can you play the video, please?
Not only that, no, the respect we are offering to GC Surana also missing.
Yeah,
it doesn't matter.
They have to, yeah.
It's come, very nice. Look at my friend,
Lamp lighting first. They could have put lamp lighting first and then.
Manjula, You should have done the lamp lighting during the inauguration. Anyway, it doesn't matter.
But Madam was not there, sir, in that video.
No, but see, at least to inaugurate, we could have done, no, because inauguration starts with lamp lighting. Doesn't matter.
Yeah. Please put Professor Narasimhalu sir's video if you have, please. Ready?
Professor Maya has got a knack of, adorning shawl.
Yeah, sir.
This
Thank
time
you.
also, Praveen, medal is missing. Every time I insist you should have medal in the oration. Manjula, last
Yes,
time
sir.
also I insisted during my oration, you must make a medal in the name of Surana oration medal. That is a memento for the orator. So I
Right.
think next time when somebody is going to give oration, make sure you give a medal.
Yeah,
Yeah.
we gave a medal in the coin, only hanging was missing.
Yeah,
Right, sir.
usually
We'll do that.
oration means you will have to have a medal.
Right, sir. We'll do that.
Manjula, this lighting lamp and honoring GC Surana are missing.
Don't worry,
There's an
Narasimhalu.
RX
Carry
event.
on.
Can you play that video if you have readily available?
Narasimhalu.
The most importantly,
Yes.
honoring GC Surana.
Yeah. Yes. Yes. Is it available with you? Thank you so much. Sorry for
Now-
some. Yes, sir. Over to you, sir.
Yeah, now Narasimhalu. Yes, we are looking forward to your oration.
May I have a slide, Dr. Manjula?
Yes, sir.
Yes. Can you have the slides of Narasimhalu, sir?
You can speak something, Narasimhalu, before the slide comes.
Yeah. Okay. Thank you, Dr. Muganathan, for your generous and kind words towards me. At the outset, my respect to GC Surana And I am very much thankful to Dilip Surana, Jayraj, Manjula, Praveen, and other team members of Fever Foundation Advisory Board for honoring me and showing confidence in me and bestowing this prestige oration on me. I was asked to choose a topic. Me being a rheumatologist, and fever is most common in SLE and rheumatology practice, especially in SLE patient, and one of the common cause of mortality in rheumatology, SLE, and infection. So I choose this topic, and I am very much thankful to all the functionaries of Fever Foundation and also the delegates for this purpose. All of you know, fever is commonly encountered in rheumatology practice, and SLE it contributes significantly to morbidity and at times mortality. Evaluation of fever is challenging in these patients due to wide array of reasons. Drugs commonly used to treat SLE are NSAIDs and corticosteroids, which may mask the clinical signs and symptoms of fever, and some drugs may cause fever. Fever could also be a presenting feature in various infectious diseases which may mimic SLE. Hence, it has been a daunting task for rheumatologists to diagnose cause of the fever in patients with SLE. Next slide. Now, what is fever? Just before going fever and SLE, let me take some basic of fever. Normal body temperature, the thermoregulator located in hypothalamus. Postglandular E2, PGE2, mediates the febrile response. Shivering takes place when there is a rapid rise to match the febrile set point. Definition: morning oral temperature reading is 37.4 and evening 37.7 or 98.9 to 99.9. A 1 degree diurnal variation is a normal variation. Next slide. And the cascade of events which occurs in SLE, antihypothalamus, the endogenous, exogenous pyrogens, mediated by through neuroendocrine mechanism and cytokine storm, which have been heard for Ramana and Chandrasekhar, which alters the hypothalamus set point and causes severe fever. And whenever fever has to decrease, the vasodilatation, sweating, fever decrease. The various cytokines, mainly PGE2, responsible for this fever in SLE. Next slide. Next slide, please. Now, in fever, hypothalamic is the most thermostat becomes set at higher temperature. Temporary rising mechanism, commutation, that is endogenous pyrogens, accounting for initial pallor and shivering. And whenever fever is abating, set temperature is lowered and the warm skin and shivering represent heat loss mechanism. That is normal pathophysiology of the fever. Next slide. See, these are the various endogenous pyrogens. IL-1, which is most potent endogenous, beta 1 interleukin 1 alpha and interleukin 1 beta. And TNF alpha, some soluble and membrane bound forms. IL-6 is directly X on the cytokine cascade. And interferon X through interferon gamma and beta, and also IL-1, IL-2. These are all the pro-inflammatory cytokines are elevated in SLE, which are also responsible for setting the thermostatus point of hypothalamus. Next slide. Now, etiology fever, central mechanism, like neurogen fever. You can cerebral stroke drugs like pontine hemorrhage causes pinpoint pupil and hyperpyrexia. And all post-stroke circulations diseases causes the fever more commonly the intercirculation. The non-central, infection and non-infection. Infection causes are bacterial, virus, tuberculosis, parasitic, fungal. Non-infectious, malignancy, drugs, surgery, myocardial infarction, pulmonary embolism, and various autoimmune diseases. My task is today autoimmune disease, that is SLE. Next slide. Now, prevalence of fever in children, all of you know, infection most common, viral and respiratory gastrointestinal infection, and central bacterial infections like pneumonia, arterial ear infections, and skin and joint infections are very common. Next slide. And prevalence of Fewer in adults. There are two studies I'm quoting. There are two are inpatient studies. Again, malaria, dengue, bacteremia, scab typhoid, leptospirosis, chikungunya in one study. In other studies, slightly variation, leptospirosis, typhus, scab typhus, influenza. These two studies are taken during the epidemic period. They doesn't reflect exactly the prevalence of fever during normal, regular phenomena, non-epidemic period. Next slide. Now, the enigma of fever in lupus patient, just to introduce. So, coming back to now the etiopathogenesis and clinical dilemma of fever initially, fever is commonly encountered in rheumatoid practice. With SLE, it contributes significant mortality and morbidity at times. Evaluation of fever is challenging in patients due to wide variety of reasons, because drugs commonly used to treat SLE, such as NSAIDs, corticosteroids, may mask clinical signs and symptoms of fever, and some drug may itself can cause fever. Fever could be a presenting feature in various infectious diseases which can mimic SLE, like lupus, mimicus. Hence, it has been a daunting task for rheumatologists to dissipate etiology of fever in patients with SLE. Next slide. Now, fever in SLE patient, common manifest SLE, according to 36 to 86%, rarely fever may be the only presenting feature of SLE, as pyrexia of unknown origin, and 5 pyrexia unknown origin of SLE. Assessment of fever in lupus is very challenging. What is the cause of fever in SLE? Pyrogen cytokines such as interleukin 1 beta, interleukin alpha, interleukin 6, TNF, and interferon beta and gamma are produced by activated macrophages and monocytes and act on the hypothalamus to produce fever response. All of you know these are elevated. These are the cytokine storm, which is responsible for changing the set point on the hypothalamus and cause fever. SLE patients often have enhanced interferon serum levels, and level correlate with double-strand DNA, which correlates with disease activity production and decreases and the causing fever in SLE patient with active disease. SLE patient with increased interleukin 17, which induces secretion of granulocyte stimulating factor, positive, and feedback loop phenomena, which again increases interleukin 7. Interleukin 7 increases granulocytic stimulating factor, and granulocytic stimulating factor increases interleukin 17, which all causes cytokine storm, which changes the cytokine flow, which changes the set point of hypothalamus thermoregulatory point. Next slide. Now, you can see in what causes lupus fever. Number one, lupus is a B cell hyperactivity disease. And B cell, whenever get hyperactive, there will be inflammation. Once there is inflammation, the hematopoiesis and antiphospholipid antibody production and various cytokine storm gets triggered, which activates reticuloendothelial system and innate immune deposition, tissue injury and destruction in kidney and waste organs, which all liberate these interleukin 6, interleukin 1, interferon, and TNF, which changes the thermoregulator point of the hypothalamus, which causes fever. And infection also more or more same mechanism. The mechanism of fever production in SLE and infection more or less identical, but the treatment of both are different. It is a diagnostic dilemma for all clinicians. Next slide. Now, what are the clinical features? Fever is a common with SLE, which occurs 36-86%. Patients with active SLE without infection, the peak temperature usually from 30 to 40 degrees centigrade with intermittent pattern. But any type of fever can occur in SLE. It could be continuous, it could be remittent, or it could be intermittent. The differential diagnosis for fever in lupus patient include disease activity. Systemic lupus erythematosus active without infection can cause fever. Disease in remission, but infection can also cause fever. Disease also active, infection also active can cause fever. Now, disease in remission, there is no infection, may be concomitant disease like malignancy, sarcoidosis, leukemia, lymphoma, and other malignant disorders, very common SLE, they also can cause fever. And drugs used in SLE or any drugs used for other concomitant disease can cause fever. So we have to categorize five categories in evaluation of lupus. Each one has a treatment changes and they contribute to mortality and morbidity. Next slide. Now, how to identify lupus fever clinically? Typically, the chills and rigors absent in lupus fever. They are present in infection. The Rowan et al. Distinguished lupus fever with three criteria. Number one, absence of infection despite extensive evaluation testing. Presence of illness typical of active lupus, accompanied like skin rashes, oral ulcer, joint pain, alopecia, photosensitivity. No evidence of infection despite escalation of immune suppression. It is important to differentiate lupus fever from infection as management varies and infection remains the major cause of newly diagnosed lupus patient and is the major number one cause of mortality in SLE. Next slide. Some of the difference points. Lupus disease activity, fever is usually low grade, where infection, fever is high grade. Fever and infection, it may be low grade or high grade. In a lupus fever, no chills and rigors. Infection, chills and rigors usually present. And infection, active disease and infection can have chills and rigors. And disease active and clinical parameters, active systemic disease are present with oral ulcers, skin lesions, joint pains, alopecia, and photosensitivity. They are usually absent in infection. They can be present when both the disease active and infection also active. Next slide. Now, we have conducted a study in our ESI Medical College with our one of the DM student, and from April 22 to August 23, and we have taken nearly 196 patients, and where we assessed all the demography data, and SLE activity was measured for SLEDI 12K, and various clinical and immunology and biomarker evaluation for infection carried out. Next slide. Now, a total of 192 patients were admitted during the above period, clinical evidence in fever. Out of 192 various patients, 54 patients were SLE, accounting for 28 to 30%. The demographic parameters most common in SLE was 30 to 39 years, and females contributed to almost 94.4%. As you know, SLE is more common in females. Next slide. Now, what was the age of the fever in our study? We observed that most common cause of fever in our study is flare of the underlying disease, according to 51.8% patients, and infection, only infection, 31.4% of patients. Disease flare infection accounting for 16.69% patient. Most common cause of infection was urinary tract infection, accounting for almost 16.6%. Default in drug is the most common cause of the disease flare infection in these patients. Next slide. Now, these are various disease flare were 28%, 28 patients accounting for 51%, 0.8%. Urinary tract infection most common. Next, respiratory tract infection, acute GE, dengue fever, cellulitis, herpes zoster, and tubercular pericarditis we have encountered. And disease infection was seen in 19%. Disease activity was 28%. Both were there in 9 patients in our series. Next slide. Now, the enigma of fever in SLE patient in various lab parameters. CRP was significantly elevated in SLE patient with infection compared to those disease flare in concordance with this study. As opposed to previous studies, neutrophil lymphocytic ratio was found to be elevated in patients with SLE disease flare and those present with evidence of infection, making it a reliable marker to differentiate infection from disease flare. However, procalcitonin was significantly elevated in SLE patient with infection, but without infection, it was not elevated. Statistically, it was significant, 0.001. Next slide. And in conclusion, in our study, fewer SLE patients were frequent finding in rheumatology clinic. Common etiology are infection and disease flare. High disease activity, poor drug compliance are contributing to increased incidence of infection. Onset of fever in SLE patient warrants thorough evaluation, identification etiology etiology guidelines and guides the management. Certain marker ESR, CRP, neutrophil lymphocyte ratio, procalcin have been found useful in differentiating the infection SLE. In our study, CRP, procalcin were found to be very useful in differentiating infection from the disease plane. However, neutrophil lymphocyte ratio didn't found much utility in our study. Next slide. Now, mortality in SLE, number one is infection. And infection more common when the disease is active. Second is active disease, especially when kidney, heart, lung, and brain vital organs involved, and cardiovascular involvement. In case atherosclerosis or lupus, pericarditis, myocarditis, endocarditis, all contribute. The various studies we can see which are different, more or less identical, saying infection number one cause of death. So prompt treatment infection SLE, definitely we can decrease mortality and morbidity. Next slide. Now, infection SLE, factors associated with increased risk of infection SLE are high disease activity, high double stranded levels are very high, low complement levels, presence of lupus nephritis, leukopenia, prednisolone dose more than 7.5 milligrams, high dose prednisolone, methylprednisolone pulse therapy high dose, cycloplasma high dose regime. All these are risk factors for infection. Next slide. Now, infection SLE study has shown that respiratory tract infection most common. Next is urinary tract infection, skin and mucosa, sepsis account for most of the infection SLE. The most frequent microorganisms were bacteria, next virus, next fungi, and the systems involved were respiratory tract infection, urinary tract infection, skin and soft tissue, bacterial sepsis, and viral infection, and also fungal infection or common infection SLE. Next slide. Now, bacterial infections. Bacteria are the most common agents of infection. The respiratory tract as well as skin and soft tissue is the most common such infection. Respiratory tract infection are most commonly seen in hospitalized patient, where urinary and skin infection is seen most commonly in the outpatient. And salmonella pneumonia, Staphylococcus pneumonia is the most frequent bacteria involved in respiratory infection. Staphylococcus aureus most commonly seen in skin and soft tissue, and joint infection equally the most frequent urinary tract infection. This is the data is almost correlated with our data also. Next slide. And tuberculosis SLE play major interplay. A presence of TB around 5% has been established in lupus patients in endemic areas. Series from those areas we showed that pulmonary tuberculosis was the most frequent site, although frequency of the extrapulmonary tuberculosis also higher than the general population. Tumor necrosis factor blocking drugs greatly increase the risk of tuberculosis, although such drugs are rarely used in SLE. Next slide. And tuberculosis in SLE has interplay. SLE patient inherently immunocompromised with immunosuppressive drugs further increases TB infection. On the other hand, TB through production of toll-like receptor ligands may amplify the autoimmune response. The TB diagnosis is challenging in lupus patient because TB symptoms become atypical and mimic those of lupus, lead to unresponsiveness to purified protein derivative. That is, Montauk test may become negative because immune suppression and also effect of the basic disease of SLE is immune disease and may have a disseminated TB. Yeah, all these conditions become more challenging for the clinician to make a diagnosis and treatment of tuberculosis in SLE. Next slide. The non-tubercle mycobacteria. Non-tubercle mycobacteria infection has also been reported in SLE patient. A retrospective study of 11 SLE patients with non-tuberculous mycobacterial infection showed that skin and soft tissues are most frequently involved, usually presenting with the skin nodules, and non-tubercular mycobacterial infections are found to occur late in the clinical course, leading some authors suggest that the relationship with the steroids and the cumulative dose of the corticosteroids and the incidence of non-mycobacterial tuberculosis. Next slide. Now, viral infections, also very common in SLE. Herpes is the most frequent viral agent in lupus, followed by cytomegalovirus and human papillomavirus. Other viral infections include hepatitis B and C and influenza. A high rate of cytomegalovirus infection being described in patients with lupus. Cytomegalovirus may mimic a lupus flare, cause pneumonia, gastrointestinal bleeding, or encephalitis. Women with SLE have both high prevalence of human papillomavirus infection and also increased risk of squamous cell interepithelial lesions. Next slide. Now, fungal infections. Opposite fungal infections also caused by Candida, pneumocystine, and also cytomegaloneoformans. Infections produced by Candida, mostly Candida albicans, involve upper gastrointestinal tract and also esophagus and genitourinary tract. Pneumocystine pneumonia, although rare, is a serious complication with high mortality rate. SLE patients treated with cytotoxic agents and high-dose glucocorticoids are most susceptible to its infection agent. So, bacterial infection, viral infection, candida infection, more common in SLE than non-rheumatological conditions. Next slide. Now, other causes of fever in SLE, apart from infection and lupus, the concomitant diseases like sarcoidosis, vasculitis, other autoimmune diseases, rheumatic fever, malignancy, and drugs also cause fever. We should identify these also because treatment again different. Drug fever, just drop the drug. Malignancy, appropriate treatment, malignancy required. Rheumatic fever sometimes coexist. And other autoimmune diseases like sarcoid, vasculitis also we have to consider in a patient with lupus, systemic lupus erythematosus with a fever. Next slide. Now, how to differentiate all the 5 categories? Commonly used markers in HL include double stranded will be elevated when the disease is active, complements are low in active disease, ESR will be elevated in infection and also in SLE. In CRP is elevated in infection but not elevated in SLE. This is one of the important points. And complements are low in SLE. And active urinary sediment. All these suggest active lupus disease. Next slide. Now, the findings for diagnosis of lupus fever or infection are leukopenia, normal, slightly elevated CRP. Usually CRP normal in active lupus also is doesn't get elevated. Low complement, elevated double-strand DNA. Next slide. Now, CRP increased significantly in SLE patient with a concomitant infection, and SLE remission infection active also gets elevated. Presence of CRP antibody also helps. Reduced production of defects in interleukin 6 also occurs. Interferon alpha is inhibitor of CRP promoter activity, and high resolution CRP more sensitive test with more than 6 milligrams associated with active infection with 84% specificity in SL patient. Routine CRP is less sensitive, specific and sensitive, where high density CRP is found to be more helpful in differentiating infection from active SLE. Next slide. Now, ESR is important, very routinely commonly done, is indirect phase reactant, reflects plasma viscosity, presence active disease, the ESR elevation, common SLE, often measured as a potent indicator of disease activity. A wide range of factors can influence ESR levels such as old age, female, anemia, renal disease, hypoalbuminemia, hypercholesteremia, hypergammaglobulinemia, malignancy, may all. It is not that specific to identify SLE, but take other lab parameters, clinical parameters definitely helps. Next slide. Now, there are further modification, ESR CRP ratio. CRP ratio must be useful to differentiate between infection and disease. ESR and CRP ratio more than 15 significantly correlate to the disease activity, whereas ESR to CRP ratio less than 2 associated with infection. Next slide. Now, procalcitonin is very important. It is elevated in infection. It is not elevated in active disease. And in SLE patient, it has been found to be more than 0.3 nanograms with a high sensitivity of 74 to 75%. It has a 95% specificity. Procalcitonin is a marker of infection, but not a marker of lupus activity. So it is helpful to negate the diagnosis of infection. Next slide. CD27, the percentage CD27 expression is a B cell patient, and SL is a B cell disease. It is elevated significantly in active lupus. CD27 could therefore be a good marker of disease activity, but is not commonly available in most of the labs. In some of the rheumatology, wherever the rheumatology department there, these markers are available. Next slide. Monos binding lactin, one of the one more biomarker, innate immune system protein that recognizes the monos carbohydrates, the sugars of microorganisms, activates the complement system. A serum level of more than 0.5 is a sensitivity of 82%, specificity of 82%, negative is possesses increased risk of infection without SLE infected by pneumococcus. Low levels are seen in patients with musculoskeletal cutaneous manifestation SLE, with intermediate high levels are seen with nephritis. So these are one more new biomarker to differentiate infection and SLE. Next slide. Now, various biomarkers in study are CRP, procalcitonin, monos binding capacity CD64, and OSA, and CD27, and these are different biomarkers are available. But most common biomarker available CRP, ESR, procalcitonin, monos binding are available only few of the laboratory wherever the department of rheumatology. Next slide. Now, measures to prevent infection most important SLE, because we already know that infection most common cause of death in SLE. So vaccination, we know adult vaccination become popular. Vaccine against influenza, hepatitis A, even papillovirus, influenza B, Nigerian meningitis, and staphylococcus and tetanus, very important, and definitely can decrease mortality. Inactivated live vaccine are best avoided when a patient is receiving immunosuppressive agents, including glucocorticoids, when the dose is more than 20 milligrams. Because when patient has immunosuppressive dose, SLE and remission regimes are there. The inactivated vaccines, the efficacy will come down. So once the induction phase is over, then we have to go for inactivated vaccines. Next slide. Next slide, please. Now, hydroxychloroquine, one of the most important drug in SLE, you should not stop to continued lifelong. It has antibacterial, antifungal, as antiviral effects, well-known antiparasitic activity in malaria, and it also have an effect on significant both B cells and T cells. The first two effects are excreted by pH-dependent iron depletion, increasing lysosomal pH, leading to growth and inhibition of intracellular organisms. All intracellular organism multiplication significantly get retarded by hydroxychloroquine. SLE remission and low disease activity should be maintained with the help of judicious use of steroids and other immunosuppressive drugs. Control the lupus disease activity, essential control as early as possible. Let SLEDI be less than 1 or 0. Infection rate come down, and death rate come down due to infection, and mortality to lupus also come down. Early aggressive therapy with prompt immunomodulation regime, whatever the NIH regime or Eurolupus regime or IR regime, whatever regime you want to use it, prevent organ damage and minimize the mortality as much as possible by appropriate immunomodulation. Next slide. Now, preventing measures. The measures prevent infection in systemic lupus erythematosus. I told early control the disease and vaccination and INH prophylaxis sometimes, and we should avoid BCG vaccination whenever disease is active. Do not use long-term prednisolone more than 5 milligrams per day, because more than 7.5 milligrams increase infections are there, and use low-dose methylprednisolone and use cyclophosphamide low-dose regimes as high-dose regime. Give hydroxychloroquine to all SLE patients so that the organ damage prevention and mortality to the infection will come down significantly. Next slide. And these are my various references in my talk. Next slide. Next slide. This is my last slide. Next slide, please. Now, hope my talk on SLE and fever is a clinical dilemma for all clinicians, differentiating by clinically evaluation, good history taking, examination, immunology, biomarkers, help to differentiate the clinical picture of fever is due to SLE or infection or both or none are there. It is associated with concomitant malignancy or sarcoidosis or drug fever. Appropriate identification treatment will definitely help to minimize morbidity, mortality. And thank you once again, this Pure Foundation.
Thank you very much, sir. Over to Muruganathan, sir. You're there, sir. Dr. Muruganathan, sir. I think, sir, isn't. So, thank you very much. Dr. Sudarshan, sir, you would like to thank him, and since you are also in the chair, sir.
Yeah. Thank you, Dr. Professor Narasimhalu and other members of the Fever Foundation. Your lecture, of course, I am an epidemiologist and a community medicine person, and yours was a purely clinical subject, and but still, I have found it personally very interesting, and your lecture definitely will be useful to that, useful to the physicians and pediatricians and other infectious diseases specialists who are attending this FEFCON. And I take this opportunity to thank Surana family for supporting FEFCON and also the Fever Foundation. And personally, I thank you for delivering this oration lecture. Thank you very much. And usually oration, there are no lectures, there are no questions. And with this, I conclude, and it is back to Dr. Manjula, please. Yeah.
Thank you, sir. Thank you very much. Thank you, Professor Narasimhalu, sir. We will move to the next session, which is near diagnostic in infectious disease. The session will be by Dr. Camila Rodriguez. To chair this session, we have a very eminent microbiologist with us. We are privileged to have Dr. Balaji Veeraraghavan, sir. Sir is from the Hilda Lazarus Crowe Research Chair, Microbiology at Christian Medical College, CMC, Vellore. Sir, special interest includes sepsis, vaccine preventable invasive bacterial diseases, antimicrobial resistant mechanisms, surveillance, and molecular epidemiology. Sir has been the principal investigator for various studies, to name a few: vaccine preventable invasive bacterial disease surveillance by WHO CRO and ICMR Collaborative Center for Excellence. He has several honors and acclamations. Some of them are Indo-US Science and Technology Fellow, Tufts and Harvard Medical School, Global Infectious Disease Research Fellow, NIH USA, Charles Shepard Science Award from CDC, Atlanta, USA. He has more than 14 publications, reviewed article with more than 9,000 citations. Sir, it's our pleasure and privilege to have you with us, sir. Welcome to the session. May I now request you to kindly chair the session and conduct the proceeding. Over to you, Balaji, sir. Sir, you're on mute, sir. Can you unmute, sir, please?
Can you hear me now?
Yes, sir.
Can you hear me? Yeah, sure.
Yes, sir, we can hear you.
Thank you, Dr. Manjula. Thank you. Thank you very much, Dr. Manjula. So it's a great honor and privilege for me to introduce Dr. Camila Rodriguez. She is the face of microbiology in India. Microbiology in sense of diagnostic microbiology. She is the consultant and microbiologist and chair of infection prevention control Hinduja Hospital. She is very popular and very well known in the international circuits. She is the current member for a newer diagnostic work group in Stop TB, and she is member International Affairs Committee for the ECMID, and she is member in the Rescue TB International Consortium Expertise for WHO, FIND, NIAID, and she is also the advisory committee for MDR TB of WHO CRO region. So, apart from international recognition, she is part of the national, either as an expert or member, as special invitee for several national working committees for the government of India. This includes for tuberculosis, newer diagnostics, and for antimicrobial resistance. And she also is is the past president of Indian Association of Medical Microbiology. To her credit, she has got 360 peer-reviewed publications and almost more than 105 projects funded by international agency and national agency she has done, and she is recipient of more than 24 awards. So it's a great honor to introduce her, and it's also a privileged honor to listen to her talk on newer diagnostic for infectious disease. Unfortunately, I think today she is not around, means she's not giving the live talk, rather the recorded speech she is delivering now. Yes, please, Dr. Manjula.
Yes, sir. Thank you very much, sir. Thank you so much.
Dr. Chinappa for inviting me to this fever symposium. My topic is new diagnostics in infectious disease. And I'm going to actually just speak about initially the 4 moments of antibiotic decision making should proceed in this way. Does my patient have an infection that requires antibiotics? Have I ordered appropriate cultures before starting antibiotics? And I'm going to focus on that. What empiric therapy should I initiate? After a day, can I stop the antibiotics? And what duration of antibiotics am I going to give my patient for? So these form the basic tenets of antibiotics in any situation. So with the same technology, it's sad to say that microbiology is almost the same as it was a century ago. It takes 48 hours to grow a bug. So we clearly need faster tests for better care. And optimal microbiology really needs best or really good sample collection. That's really, really important. It is the weakest link. It should be rapid, accurate, and cheap. So when you look at the diagnostic options for detecting pathogens, we look at direct demonstration, we look at supportive evidence such as antigen antibody, we look at how we can optimize the isolation, and today much more than in the yesteryears, molecular methods to multiply the bugs. I'm just going to briefly touch on direct microscopy because it's really fast. And to me, the newest technology, it has been there for many years. But just to sort of put into perspective, this is microscopy. So you can see nothing here. But when I add an optical brightness such as calcoflow white, the fungus leaps out at you. It enhances sensitivity in a normal KOH by about 15%, as well as it's really fast. So now I'm going to just ask one question. What did these 6 patients have in common? All were empirically started on antitubercular treatment and ceftriaxone. But when you look at the smear microscopy, when an attempt was done to actually, to get the pus out, the first was gram-negative bacilli, Citrobacter kozeri. The second was gram-positive cocci, Streptococcus species. The third was nocardia. And the lower smears are, one was MTB, one was toxo, and one was a fungus called Cladophylophora bantiana. So what did these patients with these 6 space-occupied lesions in the brain have in common? Nothing. In fact, empirical therapy was clearly inappropriate in 4 of 6 cases. And we need to attempt to identify the offending pathogen should really be paramount. So we need to culture every tumor. Our dictum goes, culture every so-called tumor and biopsy every abscess. The second is supportive evidence, detection of antigens and biomarkers. Now, I've just sort of listed the 3 main causes in pediatric aspects. One is fever with rash, fever with lymphadenopathy, which may be generalized or localized, and AUFI. So AUFI less than 5 days and fever more than 5 days. You have various, symptoms the patient may come with, and these are the various tests. All of you are familiar with this. I'm not going into this. But just to sort of reiterate, the antigen antibodies have really made a big difference in today's world, especially antigen detection. Pneumonia, the Binax urinary antigen for strep pneumoniae and Legionella is really, really a good test. Similarly, for meningitis, there's the latex antigen, which all of you know has been around for many years. But in Cryptococcus neoformans, there's something known as the CRAC test. It's really useful because it can be literally a dipstick test. It's an LFA, that's a lateral flow assay. And this is actually replacing the latex agglutination. For malaria, dengue, chikungunya, for Kala Azar, there's an RK39 antigen test. And for scrub typhus, there's an IgM test that is fairly good. And of course, SARS-CoV-2, we know there's LFA, which is really fast in addition to the PCR. Now, this just shows you the pneumococcal antigen test is really very sensitive, especially when it's done in meningitis and patients who are on treatment for at least 2 to 48 hours, you will not get a smear positive, culture positive. So this sort of helps to establish the diagnosis when you use the pneumococcal antigen test on the CSF. And this is the CRAG antigen I just spoke to you about. It can be done very easily. It's stored at room temperature, and it has great sensitivity and specific for all the 4 serotypes of the Cryptococcus neoformans. Now, the other ones, we all know about the various, the malaria antigen test, dengue NS1, etc. But 2 tests I thought I'll talk about. One is BD-glucan for invasive fungal infections, and the other is galactomannan, again for invasive aspergillosis. Now, serum BD-glucan is becoming an important test in ICUs. Again, because that's where you start suspecting Candida, Aspergillus, and a really good test to rule out PCP. So these are the 3 indications for doing a serum BD-glucan, not so much in the OPD, but for most fungi except Cryptococcus zygomycetes, that is the mucor group, and blastomycosis. But the downside is you do see several positives with patients who are on antibiotics, certain organisms, gauze, etc. And in our limited experience, we found that it's a really good test to rule out the infection. So it has a good negative predictive value, which is almost 100%. The other test is galactomannan when you're suspecting invasive aspergillosis. And again, different thresholds for different patients. Neutropenics, it's really a useful test. Different sites when for example, in patients in ICU where you're suspecting aspergillosis, the BAL is a useful sample. And these are the cutoffs for IPA. In neutropenics, like I said, serum galactomannan is really useful, but in non-neutropenics, we have to resort to the site, such as BAL. Again, false positives such as tryptase or certain other fungi and plasma light, etc., may give false positive. This is a really useful test for carbapenemase detection. Again, not in OPD practice, but in ICUs, where you don't have to do expensive tests such as expert molecular tests. This from a culture will give you the result in literally 15 minutes and tells you whether you're the type of carbapenemase responsible. We are finding it extremely useful in management of our patients because it's much, much cheaper. The biomarkers in sepsis, I'm not doing the lower ones, but just to make one point, CRP, it's a point of care test, it's cheap, and it's encroaching on procalcitonin strengths. It's becoming a really useful test in AMSP, from antibiotic initiation to limiting the duration and even to de-escalation. The third point is successful isolation and ID. Now, we all know blood culture is the most important test in a person with fever, and these are the automated methods which we find are definitely better than the manual because they don't have issues of routine subculture, they don't have issues of contamination, etc. But one point I think I must make, that blood culture collection recommends that you just don't do one set or you don't do one bottle. Solitary cultures are simply not advised. You need 2 sets at least, one aerobic, one anaerobic means that's 1 set. Because for one real reason is that increasing the volume enhances the chances of isolation the bug. And again, because kids are so difficult to collect samples from, usually end up growing contaminants whilst collection. So if you do, like this the slide shows you, if you do 1 of 3 sets, its chances of being a contamination is 97%. But if the lower one, 3 of 3 sets is positive, that bug is 100% significant. Which is why we say this is for the isolation rate for 1 set, 65%, 2 sets, 80%. By this I mean recovery in endocarditis, and 95% for 3 sets. 3 sets maybe is a bit of an overkill, but at least 2 sets. And in pediatrics, these are the volumes that are listed by the weight, the recommended volume, blood volume of the child, and the volume of blood collected should be 1% of the patient's total blood volume, and this is the volume that would be as per the weight. Now, this was a nice article that showed about blood culture collection and a call for diagnostic stewardship. This tells us that when do you absolutely have to do a blood culture? One is when it really gives you good diagnostic value in sepsis and infections that are associated with high or intermediate risk of bacteremia. And from an ICU perspective, these would be endovascular infections, and from a community perspective, these would be enteric fever. When do you repeat blood cultures? clearly when you have Staph aureus, clearly when you have Candida, etc. Now, there's been a huge amount of advance in diagnostic microbiology, and there has been a tsunami of new technologies. One of them is MALDI-TOF. MALDI-TOF MS is really revolutionized the identification of bacteria, fungi, and mycobacteria within minutes. It kind of is a one-size-fits-all workflow, and you can see this is the advances in microbiology. From traditional biochemicals, all of you must have remembered the in-vitro reactions, that's all over. The API manual, the Vitek ID, and today we talk about MALDI-TOF. And the reassuring part is that India is now getting increasing number of MALDI-TOFs because it's identifying bacteria and fungi within 20 minutes, and potential applications for susceptibility testing are being explored. Remember, MALDI-TOF is for identifying, not so far for susceptibility testing. So basically what we do, I'm not going to just bore you with the details, we just take one colony, put it on the slide with the matrix, and the particles, the organisms are sort of, the particles in the matrix are ionized, separated as per their mass to charge, and they are measured like this, in kind of a spectrum, which really defines an organism very, very accurately. And we are using it in our lab for blood culture. So when our sample comes positive for blood, we put something on a blood culture, on an agar medium, and within 4 hours, we are able to MALDI-TOF it. So it really has reduced the time. This is pre-MALDI-TOF, we used to take so long, rapid identification, whereas here, we've we managed to gain about 24 hours to identify a bug. And to me, that's a lot of time. So let's take this case of a 5-year-old neonate with diarrhea who spiked fever. The blood culture grew these aerobic spore bearers. Believe me, before the MALDI-TOF era, we would have dismissed this as nothing. This is some bacillus spore-bearing organism, leave it. The MALDI-TOF gave an identification of Bacillus clausi. When we looked at where did this bacillus come from, it actually came from, Bacillus clausi is Enterogermina and is exclusively administered orally. When Enterogermina should not be given injected, but this child actually was being given this probiotic Enterogermina. And all we had to do was tell the pediatrician, please stop it, because this was migrating from the gut. So we have started using MALDI also for yeast and molds, as well as for mycobacterial identification. And AST is still being studied. This is a case we had the other day. It was a case of BCG lymphadenitis, clear case of BCG lymphadenitis. And this came as a referral from somewhere. We got the plate of the organism growing on a plate. It was a slow growing mycobacteria. Strangely, these are what we see. NPT64 is what we swear by, that it's got to be MTB. But MALDI identified it as MTB complex. And when we reported to the pediatrician, he said, oh, but I'm suspecting M. bovis. But remember that when we say MTB complex, it also includes M. bovis. And M. bovis is actually coming from BCG vaccine. So MTB complex is not exclusive to M. tuberculosis as an infection. It's also present in M. bovis. This is still not available in India, but I think this will be a huge advance because it can be done directly from the patient sample. It's not a molecular method. It's basically magnetic resonance-based technology, and it deploys nanoparticles, and I believe it can even detect 1 colony per mil. So that's a huge advancement, but currently it's very, very expensive and we simply can't afford it. But the fourth and most important is molecular tests. So there are drawbacks of current diagnostic methods. We know blood cultures will not flag positive and sometimes in frankly septic patients. Yeah, like I said, detection of contaminants, especially MRSE, may lead to inappropriate therapy. Sputum cultures, 40% of patients can't produce sputums or they submit poor quality sputums. And it's really difficult to sort of isolate the real pathogen after antibiotics are started. Similarly, for urine culture, sample collection and transport is a huge issue. And asymptomatic bacteria we often end up treating inappropriately, of course, asymptomatic bacteriuria in children. Now, I'm showing you this chart because it's the modern tools for rapid susceptibility testing. So when something grows in culture, we have molecular methods to quickly identify the mechanism of resistance operational. And we've started using blood culture IDs called the BCID2 panel. Not so much for ID, because we have MALDI-TOF, but it also gives identification of so many organisms. More importantly, it gives you antimicrobial resistant genes. It tells you about the carbapenemases, it tells you about colistin resistance, it tells you about ESBL, it tells you about methicillin resistance for gram-positive and vancomycin resistance as well. And the targets are really convenient. Just look at the time you get. You have the specimen in routine, you take about day 3, day 4. And here we've reduced it to day 1 by quickly telling you the AMR, that's antimicrobial resistant determinants, within a day. So that was when you actually had to get a culture positive. But the best way to identify today is molecular identification directly from the patient sample. Remember the previous one, you actually had to get a blood culture positive, then you could do the rapid test. But today, now you have assays that are available directly from the patient sample. And why do we want to directly do molecular tests? For several infections such as HPV, fastidious organisms, Brucella, H. pylori, CMV, etc. So in a single cartridge, you can detect viruses from SARS to Ebola to Noro, etc. And the bacteria that you can detect from a single cartridge range from Strep A, GBS, Group B streptococci, Clostridium difficile, and of course, we are all familiar with TB. To me, it's much more important to detect the targets for antimicrobial resistance. So you have the MRSA, you have VAN-A, VAN-B, you have the CARBA-R. But remember, I told you this CARBA-R is slowly getting replaced from with that LFA that I showed in the beginning. And these are the ones for MTB. What is now going to be really important is that we're going to start using the sepsis panel. Directly from the patient who's suspected of sepsis, there are these assays, SeptiFast, etc., which can actually pick up so many bacteria, fungi directly from the patient's blood and also tell us something about resistance genes. So these syndromic panels are now doing the rounds, and they are good because they offer minimal hands-on time for sample prep. Their problem with cultures, we don't grow, it delays the treatment. And sometimes, we need to really have the right targets for appropriate pathogens with clear algorithms and guidelines defined. This is a multiplex tropical fever panel that we just started using about a year back, and we found it very useful for fever because it picks up malaria, it picks up chikungunya, rickettsia, dengue, Zika, salmonella, leptospira. Very, very useful for when the routine tests, and it takes about 4 hours to come to, and it is a multiplex, so you can get all of them in one go. There are multiplex panels for MTB, NTM. There are multiplex fungal panels, which we are also using for Aspergillus, mucor. And we started using these singleplex PCR panels for melioid and for PCP. Now I'm showing you this because just to show you that in enteric fever, we were having a big problem in actually identifying the correct nucleic acid amplification target, because there are many target antigens available, but I always feel that somehow in enteric fever, maybe the load is less because you need a load of, at least 5 CFU per mil to be picked up. So we're trying to optimize enteric fever because that is still giving a little low load, but we're looking at this. Now, this is the syndromic panel, that the film arrays. And you're having a huge panel from upper respiratory tract infections, GI infections, meningitis, so many target bacteria, viruses, etc. So do we really need them? Yes, it's simultaneously detecting several pathogens, sensitive and specific. It's rapid, and it's really a better diagnostic when you will accurately diagnose patients who will benefit from antibiotics. No, because you will only get what is on the panel. A bug that is not on the panel will not light up. Of course, it is a huge issue about cost. It's proprietary, and sometimes when you isolate a virus or 2 viruses, it may not change management. So let's look at this 11-year-old female who came to us with fever and headache, vomiting 1 episode, and she had neck rigidity, clear neck rigidity, and the CSF routine showed a WBCs present. She was started empirically on ceftriaxone, and this panel actually showed that she was in enterovirus. So we could clearly stop ceftriaxone and continue on symptomatic treatment. She recovered uneventfully. And this chart just shows you the panels that are available today: meningitis, GI, respiratory, lower respiratory, or the pneumonia panel. And this is a very useful panel that we've just started using, the bone and joint, which has 8 AM panels on board. At the same time, I think we need to remember that multiplex panels sometimes pick up too much. There's asymptomatic colonization. So these organisms such as rhino, boca, adeno, these bacteria such as mycoplasma and chlamydia can sometimes just be colonizers. But these are the true pathogens. Influenza, RSV, SARS, metapneumo, and parainfluenza. And another point is that sometimes infections with these others like rhino, boca, etc., may continue to shed, and the patient may have recovered from the infection when you still pick it up. Co-infection with bacterial pathogens, super infections are also known. So now today, you needn't waste your money on doing the full panel. There's something known as a spot fire panel, which is just offering few tests. And there is an influenza panel, influenza A, B, H1N1, H3N2, RSV. And there are individual panels such as the expert offers 3-in-1, COVID, flu, and RSV. And finally, by 2026, friends, we'll be detecting more than 500 pathogens on a microchip. The era is coming soon. The challenge is going to be, this is conventional testing and this is metagenomic testing. You're going to have, when we cast this wide net, we're going to have to interpret. So our clinical skills and from our microbiology skills, our skills are going to improve a lot. Because in pneumonia, we know that we don't isolate 15 to 25. In meningitis, 50 to 70%, we don't know what is the cause sometimes. And in fever and sepsis, again, we don't isolate so much. So it's important to have actionable information for early treatment. And when you use something called metagenomics, just look at the range of febrile illnesses you can isolate from a single sample. It's unbelievable. So this is the era that we're going to go to. And we need to address these questions. Ultimately, how ill is the patient? I think these will prove useful when patients are really ill. What are the duration of the symptoms? What are the comorbidities and how immune suppressed the patient is? So we have, these tests will have to undergo the ring of fire test as to how accurate they are. They are usually very accurate. What is the diagnostic decision efficacy? What is the therapeutic efficacy? What is the patient outcome efficacy? And what is the societal? I mean, cost-benefit ratio is important. Finally, friends, accurate and rapid time to result is essential. Timely coordination in discussing positive results with the clinician is really key. Thank you. Thank you.
It was an excellent lecture from Dr. Camilla Rodriguez. She has covered almost all the rapid diagnostic tests available today in most of the corporate hospitals. But unfortunately, the affordability and access to all these diagnostic platforms may not be available in the primary and secondary care. Actually, in majority of the time, it may not be required in the primary and secondary care settings. But if it's available, it's well and good. Since so many platforms are available, now, really, we are over the years, we could easily comment saying that these days, two important factors is accessibility to those testing platforms and affordability of the patients are the two critical points for a right diagnosis to be made. So apart from that, when it comes to the diagnostic yield, sensitivity, specificity, if you have any query about any test, I am happy to take the question on behalf of Dr. Camilla.
Can I ask a question, ma'am?
Yes, sir.
Please, Doctor.
Yeah, Dr. Balaji, thank you very much for helping out with answering the questions. Yeah, so my question is, see, the cost of this rapid tests like BioFire is prohibitive, especially
Yes,
if you're looking. So why aren't single tests available? Like, for example, supposing I'm suspecting, let us say, Bordetella pertussis. Why can't I just send only one of those for testing rather than the whole spectrum?
Yes, sir. Many centers have got a monoplex testing, but the clinician should have a high index of suspicion for that particular diagnosis to confirm. So if you are very sure, definitely that is the best thing we can do for the patient. We can save a lot of money. It will be very economical, and we will be good at it. So it's a good question, and only problem is the confidence of the treating physician. The clinical diagnosis is very important for that, sir.
Okay, and one more question I had is there were some reports of NS1 being positive in COVID also. So how true is that, and is it really a matter of concern?
Just we were also slightly confused. We were not sure. These days they are saying that infections are due to multiple pathogens. It's not a single infection. So truly, we are finding it difficult to distinguish whether co-infection is there or it's a mono-infection alone is there. So it's over the time only we will know, sir. This is the observations we are making from the clinical laboratory.
Right, sir. Because there was a study from Thailand which showed that patients who were diagnosed with COVID also were positive for NS1 antigen. So whether there is whether it is a co-infection.
Correct. In youngsters, even the RSVs are there.
Correct,
so it's a multiple infection, co-infections we are seeing now.
Right, sir. Right. Sir. Thank you, sir. Thank you.
Thank you, sir. Thank you very much.
I think there are no more questions. Thank you very much, Balaji sir. It was really wonderful to have you as chairperson. And thank you.
Thank you.
Thank you, sir. And
thank you, doctor.
Thank you for taking the question as well. Thank you very much, sir.
Thank you, Dr. Chinappa. Thank you.
Thank you, sir. Thank you.
So thank you, Dr. Camilla, madam. It was really wonderful. And a lot of people got a lot of insight into the newer diagnostics methods. I think with that was the last session of today. Dr. Jagdish Channappa, sir, if you can do the closing remarks, then we can close today's session, sir.
Thank you very much, Dr. Manjula. I think it's been a really exciting evening because we started off right on time and right on. At the outset, I would like to thank the Surana family, which has been like a mentor for the Fever Foundation. Microlabs has supported Fever Foundation unconditionally with all the facilities. I must thank also Mr. Jairaj, Dr. Manjula, Mr. Krishna, Mr. Girish, and Mr. Praveen Singh for being at the back, and of course, Dr. Raja, Mr. Raja, who is also present here today. The advisory board, Professor Maya, Professor Sudarshan, Professor Muruganathan, all my fellow internal medicine specialists and my pediatric colleagues for having pitched in and helped the team put together a fantastic program. The exemplary orator of the day of the Sri GC Surana oration, Professor Narsimlu, brought out so many things that it was really fascinating. Thank you very much, sir. The chairpersons and speakers, Dr. Chandrasekhar, the Einstein-like rheumatologist who comes up with really fascinating aspects of rheumatology. Dr. Ramanan was like, as Dr. Yanmurthy said, was like an express train, but he brought out all the major facets of the cytokine release syndrome. We must thank Dr. Soumya Swaminathan for inaugurating the FEFCON and giving her words of wisdom of setting up a joint kind of simple research facilities right across the country. Dr. Camila Rodriguez, of course, gave one of the most delightful lectures on what are the newer diagnostic entities. Dr. Balaji was present to help out with most of the questions. RX Events did a fantastic job in the telecast of this and the webcast of this, and I thank them for that. And of course, we must also thank all the students for the poster and quiz participation. And of course, the 60,000 registrants for whom this probably would have been the pre-dinner appetizer, and now they can go in for a good dinner. So thank you all for a wonderful evening and best wishes. Good night.
Thank you, sir. Thank you very much. So with this, we close today's session, and tomorrow the day 2 session would start from 7 p.m. onwards. There'll be 2 halls parallelly running. In the physician hall, the topics for internal medicine, and the pediatric hall, it will be topics related to pediatrician. So thank you very much. Thank you, everyone. Thank you, Jagdish sir. Really wonderful summing up. Thank you so much. Thank you, everyone here. Thank you, sir.
Thank you, sir.
Yeah.
Live streaming can be stopped.
Yes, sir.